Okay, let's get started. So we are going to be covering endocrine today. Just keep in mind, tomorrow, Brady and Lindsay will be covering repro with you guys. Also, if you guys do have some repro questions, I can try to answer them at the tail end, as well as some endocrine questions. Important thing to know is that the endocrine system is a lot more about looking at pathways as compared to all the other modules that you're going to likely encounter. So make sure you guys are prioritizing the bigger picture, because a lot of the things that you're learning now will set the foundations for what you're going to encounter in DM, a little bit in NB, but not as much. But DM is going to be a big kind of hormone-driven component as well. So let's get started. As always, a group of us run, here's the TPLG. You guys can follow the Facebook page, and we have access to a bunch of resources as well as other Google Drives. We have our own drive. This is the link to our Facebook. The drives link is in that Facebook group itself. So feel free to join. It helps a whole bunch of peeps go through all of the different terms. There's, I think, resources for all terms. So just keep that in mind. You can bookmark it and save it for future use. Okay. The kind of the agenda for today, since I'm practicing my medical interviewing skills, is that we're going to first address a broad overview, as much as I can in terms of broad overview of the endocrine system, because there are multiple organs involved with this system. So what we will then subsequently do is make sure that you guys dive deeper into each of the actual organs, and then address any of the disorders, pathologies, and other things that arises from those actual locations. Once we're covered with that, then I'll open it up for any questions at the tail end. And from there, we can just conclude for the day and hopefully let you guys out early, because I don't want to keep you guys longer. You guys have an exam coming up and you got to study repro, big module. So just keep that in mind. Prioritize both endocrine and repro. The questions will come about 50-50. Sometimes they like to focus a little bit heavier from term to term on endocrine or repro. So I always would recommend not to just focus on one aspect. Make sure you cover both grounds very well. Let's get started. So the first thing we need to know is the pituitary gland. It's passionately known in the endocrinology community as the hypophysis. It has a dual embryological origin. Critical thing to note, the dual embryological origin is really important. Why? Because it tells you what is likely happening at each part of the pituitary and what hormones are made. The first thing to note is the anterior pituitary. It's the oral ectoderm. They either like to call it oral ectoderm or Rathke's pouch, and it has subsequently three parts. There's the pars distalis, pars intermedialis, and the pars tuberalis. Important to know those three, and we will cover the vasculature in this area in the subsequent slides. The posterior pituitary is the neurohypophysis, okay? And the neurohypophysis is actually a brain derivative. It's from the diencephalic component of the hypothalamus that has extended downwards. As compared to the Rathke's pouch, it's an oral ectoderm, right? So it's ectoderm, you can start thinking about what type of cells are likely moving from their actual initial place to when it becomes a pituitary. And you guys can see that morphological change over time as the baby continues to develop. The posterior pituitary has two really essential components that you need to keep in mind: the pars nervosa and the infundibulum. When we go over the neuronal kind of component as well as the vasculature, it will make more sense why they have two separate systems and how it intermingles with each other and how hormones are released into the vasculature. Okay, general appearance, this is how it looks. It's just a little out pouching from the brain, so just keep that in mind. And you can see histologically what is the neuro-driven versus what is derived from. There will not be questions at the end, FYI. There are practice questions and stuff posted on the drive. Just keep that in mind. We'll give you guys more information as to what to practice before the exam. The adenohypothesis, you guys can see the rich embryological kind of oral ectoderm component. You can see how like the epithelia is basically come up and change morphologically into the secretory components as compared to the nervous components of the posterior pituitary. Okay. General appearance, as long as you guys can differentiate this and you can see these little like outpouching slash, like it almost looks like little vacuoles, but you can see where it goes from the adrenal hypophysis, the anterior pituitary, to the posterior pituitary. So keep that in mind, because histology is still a big component of T2. So make sure you guys review that. I specifically do it the night before the exam, just so that I have those pictures fresh in my brain for the morning when I take the exam. Okay, what do you need to know about the anterior pituitary? It's essentially this. You need to know your chromophils. The chromophobes aren't as important. The chromophils are very important because those are your essential secretory components. The acid phils are going to be pink staining, so keep that in mind. The pink components are right here. And then your basophils are going to be purple in color, so basophils. So the little mnemonic that you guys can keep in mind is B flat, which is basophils secrete FSH, LH, ACTH, and TSH. And we're going to go over these hormones subsequently. Pig on acid is a great way to kind of remember your acidophils. Key thing, don't confuse the P for the prolactin and then GH and all of these things for what happens to the posterior pituitary. Sometimes I like switch back and forth. So just keep that in mind, keep those straight. B flat and then pigs on acid is a great way to keep your anterior pituitary hormones solid. And we're going to talk about trophic hormones versus I think corticoid hormones. So we will go over those as well. I'm seeing some questions coming in on that, but I will make sure to address them. Acidophils. So what are your acidophils? It's your somatotrophs. This is another term for what essentially is your growth hormone. Keep in mind when you're going to get to the subsequent modules, don't confuse your somatostatin that is produced at the brain level with the somatostatin that is produced at the pancreatic level. They are different in nature, and what they do is essentially the same thing, but they're released at different times. So we're going to cover the pancreas a little bit. You're going to cover it a little bit more in DM. So just keep those straight. The ones that's created and secreted in the brain, it's completely different. Mammotrophs, as simple as it sounds, it's your prolactin. And prolactin is a very unique hormone, and that it has downstream effects on your reproductive organs as well as your thyroid. So we're going to go over the exact mechanism of it, but just keep that in mind. Jot it down in your memory because it's a critical thing that they love to test on. Your basophils are going to be your gonadotrophs and your corticotrophs, as well as your thyrotrophs. Your gonadotrophs, everyone knows this. We've all taken the MCAT, or at least some version of it that stressed us out. It's the FSH and LH hormones that we had to memorize, as well as like the whole cycle. You guys are going to have to relearn that cycle once again, just like how you're going to have to learn glycolysis all over again. So keep that in mind. Corticotrophs is going to be your ACTH. It's your adrenocorticotrophins. We're going to talk about the stimulating hormones that are coming from the hypothalamic level, as well as what happens to the pituitary level in the subsequent slides. Thyrotrophs are going to be your thyroid stimulating hormone, as well as your thyrotrophin releasing hormone, and we're going to cover those as well. Posterior pituitary, this is the neurohypophysis. Pars nervosa essentially stores this. They love asking this question because everyone's like, yes, of course, like the pituitary secretes stuff. But the pars nervosa holds these hormones in place, and they're released based off of the hypothalamic stimulation that you're getting, both from your baroreceptors and your chemioreceptors that are located throughout your system. They're going to go more into that in a bit. Your two essential nuclei to keep in mind for this module is your supraoptic nucleus, as well as the paraventricular nucleus, okay? A great way to remember this, your supraoptic, ADH, so SAD, okay? And then PVN, which is the paraventricular nucleus, oxytocin, POX. So SAD, POX, if you know that, it tells you exactly what's happening. Your S for supraoptic is talking about the ADH component, as well as your paraventricular, it's going to be the oxytocin. Keep these hormones straight, okay? Posterior pituitary versus anterior pituitary, don't get it twisted. As well as what you need to know is that they're released, right? They are made at the hypothalamic level, and they are subsequently placed into the pars nervosa via the hypothalamic hypophyseal tract, okay? If you break apart those words, you can essentially tell you what's happening. They are made at the hypothalamic level. At the hypophyseal level, they are subsequently going down, and then they're stopping at the pars nervosa where they're stored, okay? Critical thing, they're unmyelinated, and the buzzword often that they like to ask is herring bodies. It causes the dilation of these axons containing the hormones, and they're eventually bound by neurophysin. So if you see these terms, they're talking about the posterior pituitary, okay? Cool. Let's talk about a little bit of the blood supply and the vasculature in this area. As always, there's a rich anastomosis whenever you're talking about hormones, so keep that in mind. With your adenohypophysis, it's directly shot into the primary capillary networks at this site. So what they often like to ask is, where does all the, the anterior pituitary hormones get put into? It's the hypothalamic hypophyseal portal veins. Critical thing, they are essential. If there's any sort of infarction, you can have a whole bunch of issues happening at the anterior pituitary as well as the posterior pituitary, depending on where the vasculature is and the hormones and how it presents in the actual, I guess, the pathological state. So we get more into that in T4. For now, you guys just need to know the vasculature, what is happening at each point, and then both the anterior and the posterior pituitary. For the neurohypophysis, essential thing is you just got to know the hypothalamic hypophyseal tract, and you should be good. Obviously, everything has to go into the blood at some point. So once again, it's going to be the capillary plexus. Just don't put capillary plexus for the posterior pituitary, because what they're often asking for the posterior pituitary is the hypothalamic hypophyseal tract. Okay. Cool. Pituitary adenomas, essential. Got to know all of these and how it presents. Each symptom is a great way that they can ask a question stem. Quick ones to remember is your acidophils, your prolactinomas, as well as your somatotrophic adenomas, which are dealing with essentially your growth hormones. Presentation, right? Nipple secretion, amenorrhea, sexual dysfunction. Now, can men have prolactinomas? Yeah, they can have prolactinomas, but what happens is that they don't have terminal lobules at the breast tissue level. So you essentially can't, have any secretions because, we've already sort of grown up and we don't have any of those ductal differentiation that you subsequently would see in females. So what happens more so is sexual dysfunction, and you're going to have some impotency and multiple other sexual dysfunctions as compared to more presentations in the female species. Your somatotrophic adenomas, this one's a great one because there's two kind of versions of it. There's the acromegaly components seen in adults, and then there's gigantism in adolescents. We're going to cover both of those in the subsequent slides, so hang tight. Now, your basophils, got to know these two. They can ask you questions based off of the basophils and the acidophils, and they can give you just a question stem based off of prolactinoma or somatotrophic adenomas, etc. Your corticotrophic adenomas, straight up Cushing's disease, okay? Key differentiator, disease versus symptom. Keep that in mind. We're going to cover that as well. And your thyrotrophic adenomas, that's hyperthyroidism. Not good. Not a good look. It's going to cause a whole bunch of issues. Thyroid issues are kind of hard to deal with because the thyroid is it's such a complex system because it has downstream effects on literally every other organ. So we're going to go over it. Important to note, pituitary adenomas can lead eventually into a disorder or kind of a presentation that you guys often have heard about, which is the bitemporal hemianopsia. So you can have hypertrophy or you can have pathological changes at the pituitary level that's going to eventually push the pituitary, which is seated at the sella turcica. Fun fact, the sella turcica is on the sphenoid bone. That's an NB problem, but for now, you guys should know it just in case, because it's something that can help you learn where everything's happening and how pathologically things change. As the pituitary gets more and more like hypertrophied, it's going to start pushing up and eventually start squeezing the optic chiasm. And that optic chiasm is eventually going to present with vision blindness at the bitemporal level. So like on both sides of your temple, the vision fields are just going to disappear. It's a crazy look when you're like, if you're an ophthalmologist or even like you're seeing it with patients with pituitary adenomas. Okay, now we're moving into the adrenals. So the adrenals are kind of a quirky little kidney hat situation. I like to think of them as kidney hats because that's what they look like. The kidneys get kind of cold, so they just need like little like adrenal hats to keep them warm at night. So kind of a quirky way I like to think about it, but it helps me remember that the vasculature is heavily tied into the kidneys. So you can think about it this way. You have a lot of blood supply because the hormones that are dictating from when you wake up all the way to when you fall asleep, as well as like the energy level that you have on a daily basis, are going to need rich vascular supply. So both at the vein as well as the artery level. So keep this in mind. Essential blood vessels, I would say one is the left middle suprarenal artery that is going to go up, and that's going to essentially give blood supply to the adrenals. You also have another branch coming off of your aortic descending aorta, so left superior suprarenal artery. Just something to keep in mind when you guys are getting to DM. I threw this in here because these helped me get through DM in terms of vasculature. But what they really like to focus in on for you guys right now is the actual layers. The capsular layer is a dense connective tissue, like hella dense. It's a nice protective capacity, and it's composed of sinusoidal capillaries that are fenestrated. Well, I'll get to the terminology as to why it's named that way. The zona glomerulosa, that's your mineralocorticoids. There's the zona fasciculata, and then there's the zona reticularis. Keep that in mind. They spell out GFR, and since the kidneys are literally like down below, you can think of it that way and keep it straight, right? GFR, glomerulosa, fasciculata, reticularis, and then of course you get the medulla, which has its own embryological origin. We're gonna get to it right now. Perfect. Dense connective tissue, right? Very small arteries, because remember, dense connective tissue, it's dense, vasculature can't permeate it too well. And they gotta be fenestrated, right? They're cortical sinusoids and they're fenestrated. Why? Because hormones are chunky particles. They can't just be casually floating around in like tiny, tiny capillaries and be okay in the secretion component. That's why they're fenestrated. So something to keep in mind. As always with everything in our body, form equals function 90% of the time. The other 10% of the time, you just pray to God that they don't test you on it. Your cortex is derived from the mesoderm. They like to ask this. Keep that in mind. So make sure you remember cortical, it's mesoderm, it's pale staining, and that's where your steroid hormones are produced. Your medulla is neural crest in origin. And you guys know one of our favorite things in med school, pheochromocytoma. Seems like everyone under the sun has pheochromocytoma. But the neural crest cells at this site get messed up. They start spitting out a whole bunch of epinephrine, norepinephrine, and that causes downstream effects. We'll get to what drugs you're going to use at one point to treat it. That's also a term for a problem too. Adrenal cortex, like I mentioned, GFR, right? The little mnemonic that was passed on to us. Sweeter as you go deeper is the dirty mnemonic to keep it straight: salt, sugar, and sex, because that's essentially what's created. Salt is you're talking about your aldosterone. Sugars are you're talking about your essentially your cortisol and your corticosterone, more so cortisol, because that's what they like to focus in on. And then, of course, when you're talking about your reticularis, you're talking about your DHEA, and then your minor sex hormones that aren't going to have too many downstream effects, but they are essential in the way you differentiate a lot of your reproductive organs early on in childhood, as well as when you're developing, as well as in early childhood. Okay, the chunky components in terms of like the actual zones, in terms of how much there is, the biggest is the fasciculata, okay? Keep that in mind. We're gonna also cover each of the regulatory systems along the way, because the regulation for fasciculata and reticularis is gonna be from the pituitary level, as compared to the glomerulosa, which is coming from your renin, angiotensin, aldosterone kind of feedback system. Keep that in mind. ACTH is a big component of 2 and 3 from the pituitary level. And I threw in a little first aid picture to keep it straight. You guys can look at multiple pictures. I'm a picture person, so more pictures the merrier. Okay, glomerulosa. Okay, once again, look at the histo. There's a histo document in our drive, as well as I think Brady's drive, as well as Lindsay's. So keep that in mind. Go look at your one for your small groups and 2 for the actual exam, because they like to just straight up be like, give you a tiny cross section like right here, and then be like, what zone are you? And then what drug is produced? And you're like, I don't know, like, or sorry, what hormone is produced? I'm still in NB, sorry, I'm still in term 4 mode where it's everything's drugs, but glomerulosa, right? It's not the biggest region, but it produces your mineralocorticoids, right? So what's going to be produced? Aldosterone. Regulatory component, it's going to be a renin-angiotensin pathway, right? Now, the correlate that you need to remember is Conn syndrome. A lot of people forget Conn syndrome because it's not like one of the big ones that you've learned, which is like Graves' disease, Cushing's, etc. But Conn's is a great one because it's a primary aldosteronism. What does primary mean? In endocrinology, anything that is talking about primary, it's talking about at the organ level or the actual system level, something's gone wrong. Whereas a secondary or tertiary, it's talking about something that's aside from the actual organ or structure that is affected. So when they mean primary aldosteronism, that means you have either like hyperplasia or hypertrophy or something of these actual cells in the glomerulosa, and they've just basically disregarded all their regulatory functions and started spitting out aldosterone. Remember, primary at the organ itself. Hypertension, potassium deficiency. So you can imagine what is happening at the kidney level when you're losing so much potassium. We're going to get into that with muscle cramps and spasms and all those things, more so when you guys are getting into subsequent years here at SGU. Okay, what did I mention about pheochromocytoma? It's going to come back every term, literally every term. They just love it. I don't know why, but everyone seems to be coming in with pheochromocytoma. Important thing, little mnemonic I use to keep it straight is the 5 P's with pheochromocytoma. It's the increased blood pressure, headaches, perspiration, palpitation, and pallor. That's a lot of them, but all you need to know essentially is that you guys have seen classical stems with this. You're going to have a lot of arrhythmias and hypertension and issues, because remember, these are your neural crest cells that have gone crazy and started just spitting out epi and norepi. Essential that you guys know that you're going to have increased levels of VMA, vanilla manilic acid in the urine. I can't pronounce drugs, let alone like hormones and metabolites. So keep that in mind. One more thing. This is something folks forgot. The staining that you're actually using here is chromogranin A. That was something they asked us, and I was just completely dumbfounded as to what was actually going on. So they were essentially asking us a question stem about pheochromocytoma, but make sure you guys keep that straight. It's chromogranin for pheochromocytoma staining in order to see if there's increased immunohistostaining in pheochromocytoma. Okay. Okay, pineal gland, you're going to get a lot more of the pineal gland in NB, but for right now, what you need to know is the corpora arenachia, which means literally brain sand, which sounds like some cool drug, but it's not. It's just these little granules that are found in the pituitary, or sorry, not pituitary, in the pineal gland, and they are essentially involved with one of the components. The exact mechanism of why we have these sands is not sure, but they are involved in the production of melatonin in some capacity. So just keep that in mind. You don't need to get too crazy into the mechanism of action with the pineal gland. You just need to know that it's derived, the actual melatonin is derived from serotonin, and that it's involved with sleep cycle regulation and how much light you get exposed to in the eyes. Now, they will literally throw a imaging or one of these pictures. In our exam, we got a picture. You might get a little brain scan showing the actual sand in the brain. You're like, yes, what am I looking at? At the 3rd ventricular space, okay? For those who haven't taken NB, which 90% of you guys haven't, it's right here. Okay, this is your first and second ventricle, and then the third ventricle is right here, and it's the posterior aspect of the third ventricle. That's where the pineal gland is. So that's a good buzzword. If you see third ventricular space, pineal gland is likely what they're asking you in ER. Okay. All right, thyroid stuff. Fun, but like also kind of scary because thyroid does a whole bunch of stuff and you guys are going to learn more about it even in term 3 and 4. So the thyroid follicles are basically lined by epithelia. And what you need to know essentially is that when we're going through the mechanism of it, all of these components work in tandem to make sure that you get proper production of your T3 and T4. That sounds like you guys are in different terms, but like it's the actual hormones that are going to be physiologically active in circulation. We're going to cover that in a bit, but for now, just stick with me and just know that the parafollicular cells, which is called the C cells or clear cells, they are a cluster of cells that are hanging out in the extra kind of cellular space, and they're spitting out calcitonin. Okay, remember calcitonin. Since you guys have already covered most of ER, calcitonin isn't as important when you are an adult. When you are developing early on as a child, as well as like when you are developing your thyroid in general as a baby in development, it's going to be important in lowering blood calcium levels, and it opposes PTH, right? Your parathyroid hormone. We're going to cover the exact mechanism of what happens with PTH as well. Remember, your calcitonin, it's going to mess with the osteoclast activity directly or indirectly. It's actually indirectly because it first goes and messes with osteoblasts. And from the osteoblasts, they secrete components that are going to then subsequently regulate the activity of osteoclasts in terms of demineralization of the bone in order to, the mineralization of the bone in order to lower blood calcium levels. We're going to cover PTH as well. Hyperthyroidism, it's bad, okay? Like you don't want exophthalmos, okay? Like it looks scary. Like it looks like you're just like death staring into like your exam soft monitoring like system. Okay, it's not fun. Toxic goiter, right, is the essential buzzword in Graves' disease. It's an autoimmune condition. Most of the times it's when IgG just goes and havocs and starts binding to these thyroid receptors and saying, hey, why don't you just start spitting out a whole bunch of T3 and T4? And your thyroid's like, sure, I'll go ahead and do that. So what you're going to have clinically is normal TSH. So a great thing that they like to ask is normal TSH, and you're going to have a whole bunch of increased metabolic activity and sympathetic activation. But the patient has normal TSH. What does that even mean? It means that the pituitary isn't spitting out TSH because the pituitary, as with everything else in our system, is counter-regulating and saying, hey, I need to like reel back in the TSH level. It can either be low or normal. So keep that in mind. I've seen it both ways, but keep it in mind that this is Graves' disease. It's typically autoimmune. It's hyperthyroidism caused by an autoimmune condition. Remember, decreased colloid and as well as increased deposition of GAGs, glucosaminoglycans, in the actual eye kind of conjunctiva area. So like it starts building it up, and this is why this lady looks like she's just about to fight someone. Cool. Next one, parathyroid gland. Okay. Two things to know. Really, I would say one, not really, no one really cares about the oxyphil cells because their function, I think, essentially is to support the other cells. The principal or the chief cells, gotta know this very, very well, okay? It's small, densely packed stuff of cells that just straight up has parathyroid hormone secreted. Obviously, TSH, your thyroid, right, and your activities of the parathyroid are all tightly regulated by your chemio and osmotic receptors in your body. And we're going to cover a little bit about that. I'm not going to give you guys too much detail because that's very much a DM and NB thing. But the essential thing is the parathyroid hormone increases blood calcium levels. Okay, essential. Let's say you have hypocalcemia and your body's like, oh snap, I need calcium. So it's going to upregulate it. Why do we need calcium? Why the heck do we spend so much energy making or increasing blood calcium levels? Because calcium is so darn important in the activation of entire metabolic pathways, okay? From anything from your little enzymes that are in your cells that need calcium as a subsequent component to activate it, as well as your G proteins, so many other things are all highly dependent on calcium. One of the great things with apoptosis, it's dealing with calcium levels in the body. So this is why calcium is such a tightly regulated system in both the extracellular as well as intracellular space. Okay, it decreases blood phosphate levels. Why? We're going to get to that. Just know that it decreases it because you need ionized version of calcium as compared to a bound version of calcium. Cool. Pancreas. Okay. You're going to cover the pancreas till death in DM, but all you need to know is that the pancreas that they're asking you about in the actual ER module is the tail of the pancreas, because at the tail of the pancreas is where the islets of Langerhans cells are. The islets of Langerhans is the endocrine component of the pancreas. The pancreas does a whole bunch of DM related stuff. We're going to cover that like the next module, but the endocrine components, it's your alpha, beta, delta, and then like I think gamma, but like no one really cares about delta. All we mostly care about is alpha and beta because that's the endocrine components. The vasculature for this, I think, is one of the off branches from the splenic artery and vein. We're going to cover that in DM as well. Pancreatic islets of Langerhans, very cool, because in terms of what they like to ask with this is very simple. It might seem like, oh, I got to memorize all these locations where things are. Essentially, they really care about the alpha and the beta cells. They care less about the delta cells, but the delta cells are important. So some folks ignore them and they missed out on the points on the somatostatins. We're going to explain that in a bit. Alpha cells are located in the periphery. So if you see like a nice bordering and like all these staining, okay, immunofluorescent staining, and they're like, oh, what is this red stuff that's like, not the red stuff, but like the green stuff that's lining your entire system? Those are your alpha cells, okay? They are going to be involved with the production of glucagon and increasing your blood glucose level. We need blood glucose, one, because our body is hella dependent on blood glucose, okay? Our brain essentially won't function without glucose running our system, or ketones, but we'll get to ketones later. Beta, it's straight up like your favorite. Everyone knows it because they're like, oh, beta cells of Langerhans. Of course, insulin. Always the critical function with insulin is lowering blood glucose level because, you know, you just had a nice meal. You got to take up all this food and get it into the cell because the cells are the actual ones who need the glucose. Clinical correlate, diabetes mellitus type 1 and type 2. Okay, keep that in mind. Type 1 and type 2, they like to ask questions about this because you guys cover it, I believe, at the tail end of ER. Now, your delta cells, okay, this one is kind of scattered through and through. Okay, so if they ask you in terms of location-wise, what's the majority? It's beta. What's located in the peripheral? Alpha. If it's scattered through and through, somatostatin, okay? Delta cells. Somatostatin is going to oppose the action of both alpha and beta. Keep that in mind. They love to ask about somatostatin whenever they can because it's the one that no one focuses in on. And then your F cells, yeah, no, that's a DM level problem, but it creates pancreatic polypeptides. Not a big deal. Just keep that in mind. Okay, diabetes insipidus versus diabetes mellitus. Diabetes insipidus, I like to think it's like sipping on, I guess, water, but like essentially, it's a huge component of a water dilution and regulation, okay? Chronic water diuresis is basically you just dropping a whole bunch of water in your urine. You are not able to concentrate your urine, and we're going to get into the mechanism of this. Why? It's going to present with excessive thirst, polydipsia, excessive drinking, and there's also a psychological component of this. So do not like get it twisted with just like that. This is just a purely pathological thing. Now, the hypothalamic version, it's the lack of ADH, right? Vasopressin. They can use both terminologies. Keep that in mind. ADH is also vasopressin / causes typically tumor or head injury, right? Because what happens, you know, you're just going down the road, you're just biking down, and then you take a tumble, and the next thing you know, you just like messed up your posterior pituitary and you're not spitting out ADH, right? Because remember, your your hypothalamic hypophyseal tract is messed up. So everything that's made at the hypothalamic level can get into the vasculature and spit out this ADH to make sure that you are retaining water and having a good balance of concentrating your urine. Your nephrogenic is a congenital or like a receptor level mess up of your aquaporins. And we're going to get into the mechanism of this when we're covering this in detail. Diabetes, very simple. You guys know this from time and time again. Everyone's told you type 1, typically a childhood, adolescent, like you just messed up your islets of Langerhans. It's either an autoimmune thing or like you just, were unluckily blessed with the fact that your beta cells were just like, nope, I'm not getting properly developed. And then type 2 is typically adult and it's diet induced. So insulin resistance because you've had too many chocolate bars for your whole life, okay? Don't Charlie in the Chocolate Factory that thing, okay? Hypothalamic, anterior pituitary. Now we're getting to the subsequent modules focused in on the actual endocrine organs. So remember, your hypothalamus, your anterior pituitary, very important. Okay, a broad overview. I'm telling you guys this, save this picture, put it onto your notes. It's very critical. And just keep this in mind because when you guys are getting into DM as well as parts of ER, this entire thing will help you explain the entire pathway. Make sure you guys are running through each of these steps and explaining what's happening. I'm going to go over it in depth one by one, but for now, I'm just giving you guys the broad overview of what happens with your thyroids, what happens with your prolactin versus your adrenals versus your somatotrophic and your gonadoaxis kind of components. Remember, these are trophic hormones. Whenever they're talking about trophic, you might not be able to understand this. A trophic hormone goes and acts on something else in order to do a downstream effect. Whereas your non-trophic hormones, right, are straight up, they will cause systemic change upon release. So you drop in some prolactin is just going to go ahead and do its effect. It's not going to go and subsequently activate another hormone to be released. So we're going to go over it in depth. As always, they love the entire pathway of what is going to affect in terms of negative feedback and positive feedback with this entire module. Your hypothalamic nucleus often creates and sends down messages to the anterior and the posterior pituitary, whether it's going to be releasing or inhibiting hormones. And of course, your endocrine glands are going to be affected by these feedback systems. Important. Most physiological changes are going to go to the hypothalamus. You guys are going to explore this further in NB. What you need to know is that stress has contributing factors, something that we're very familiar with. Hormones, right? Like straight up other things that are being spit out by the different endocrine glands, as well as the temperature changes, sleep-wake cycle, as well as so many other things are going to change your metabolic states. With the hypothalamus, it's the 4 Fs: fighting, fleeing, feeding, and fornication. The last one, I'm not going to explain further. You can ask your parents about it. Moving right along. Signaling pathways of the endocrine hormones, okay? Biochemistry essentially is the foundation by which you guys are going to build on these hormones. 1, cyclic AMP. You guys remember your GS? These are all the hormones that use it. It's the FSH, LH, ACTH, TSH, CRH, HCGH, as well as ADH. Everything else, okay, you gotta keep that separated because majority of them are GS. Everything else is gonna be like GQ or maybe some intracellular or a tyrosine level. So if you had to take a guess, right, go with GS. If you can't, then go very specifically with memorizing these mnemonics, right? Like flat champs, chug, all GS. Goat hag, it's going to be IP3, DAG, calcium, that pathway. Why do you need to know this? Because they can straight up ask you like, oh, tell me the mechanism of action of oxytocin. And you're like, well, I think it's GQ, but they like to throw it in a question stem of like, okay, the mother presents with inability to properly bond with her baby. And we want to know what is the mechanism of action that is disrupted with the oxytocin pathway. You have to explain that it's IP3 DAG and it's a GQ. Okay, keep that in mind. The intracellular ones are typically your steroid or cholesterol-derived hormones, right? It makes sense because they have intracellular steroid hormone level components, right? Steroid hormones can go into the actual cell. They can cross through the lipid bilayer and subsequently change at the transcription translational level what is being created. That's why you have progesterone, estrogen, testosterone, cortisol, aldosterone, T3, T4, as well as vitamin D. Okay. Mechanism of action of a couple of other ones, IGF, insulin-like growth factor 1. That's a good one to remember because a lot of people forget that. That is a tyrosine kinase pathway. Okay, as well as insulin. You can see why these are very important because they're often the ones that are ignored because everyone remembers the cyclic AMPs, IP3s, and the intracellulars because they're very easy. The prolactin is a weird exception as well as growth hormone because they use the JAK-STAT pathway, okay? Think acidophils and cytokines, piglets, okay? So that's a quick way of, this is all from First Aid, so this is gonna be helpful for you guys. Clinical correlates to keep in mind, okay? Essentially, what you need to know is that the hormones that are secreted at each level are located at different locations. Your gonadotrophs and your somatotrophs, club them together because remember, they cause systemic change. It's posterior lateral in terms of pituitary where they're located. Your corticotrophs and your thyrotrophs are anterior medial. And then your lactotrophs are scattered through and through. So if you have a prolactinoma, you can imagine why this the actual pituitary gets enlarged because they're scattered through and through. The entire pituitary kind of blows up. And when it blows up, it can start messing around with other brain structures that are nearby. A great example, bitemporal hemianopsia, optic chiasm gets messed up, okay? Posterior lateral cells first to be affected because remember they're posterior lateral by most mechanical damages. You bump your head back, boom, posterior lateral stuff gets messed up because your gonadotrophs and your somatotrophs are messed up, right? Next is your lactotrophs that are often messed up, and the most resilient are your corticotrophs and thyrotrophs because they're located anterior medial, right? Anterior in the front and then medially situated in there, so they're kind of nestled. All hormones except for GH and prolactin go on to stimulate others, right? Because remember, your trophic hormones go and act on something else in order to subsequently create another hormone or go and change at a systemic level, a metabolic function or change, okay? Keep that exception in mind. GH and prolactin work directly, right? They are the end products by which change is occurring. Okay, GH, or we're going to talk about growth hormone a little bit more in detail because growth hormone they love to test because growth hormone doesn't often work just by itself. It's also coupled with IGF-1. IGF-1 is straight up involved with the development and maturation as you're going through, for example, puberty, okay? Protein synthesis gets upregulated, it stimulates muscle growth, you're going to get lipolysis, right? That's why like, you know, teenagers can literally like eat anything and then like burn it off in like 5 seconds, right? Anything that they eat are essentially burnt up. Insulin like growth factor is a huge component that's playing a role in doing that, as well as of course, a little bit of your thyroid hormones. We're going to talk about your thyroid in a bit, as well as blood glucose levels. Teenagers typically have an increased blood glucose levels because their body is demanding so much of them at any given point. One, because they're growing. Two, because they need that increased metabolic demand. And you're going to cover more about it in terms of both the insulin component as well as the growth hormone component in DM, okay? Ghrelin, okay? What are the hormones that are going to go and upregulate the activity? So if you guys are familiar with bodybuilders, which I'm guessing some of you who lift are, ghrelin is a component of what a lot of people like to use to stimulate their growth hormone. Naturally, of course, don't take shots of growth hormones. Steroids aren't cool, guys, okay? Ghrelin, if you do intermittent fasting, is gonna upregulate your somatotrophins. That's why a lot of like bodybuilders will have a huge giant meal, right? And they're going to be like, oh yeah, I'm like fueled. And then like then subsequently overnight do a longer period of fasting, because ghrelin is going to kick in at the at the stomach level, be released from the stomach level, go and mess with the pituitary and the hypothalamus and say, hey, what about you upregulate more of your GH and your somatotrophs so that we can build more muscle and body? So thyroid hormone is also involved with that. That's why when you guys are seeing metabolic changes with thyroid, right, issues like with a hyperthyroidism, primary hyperthyroidism, you're going to have more of these thyroid hormone presenting, and you're going to see bone development as well as increased hypertrophy, and you can essentially have even cardiomegaly due to thyroid level issues. Estrogen and testosterone are going to do this because, one, you guys are going through puberty. Oh my God, like, wow, this is such a wonderful thing. No, it's not. Your voice breaks. Everything's going downhill from here. It's a lovely experience. Decreased blood glucose levels. Okay. This is why people do intermittent fasting. Ghrelin and the decreased blood glucose levels stimulate GH, because GH will then go and tell your liver to start doing gluconeogenesis. And gluconeogenesis is a great way for your body to reset its blood glucose levels when you're, one, sleeping, two, when you are subsequently hungry. Okay. The other thing is the negative feedback component. GH, your somatotrophins, are going to, obviously, if you created a product, it can also have a downstream effect of going and shutting down a pathway higher up. So GH is going to go and shut down GH. As simple as that. Increase free fatty acids. That's why you got to have a healthy, balanced nutritional diet. Don't just like have like McDonald's every day. Maybe have it once in a week, just live it up a little. Glucocorticoids, obviously, you got to be very tight when you're regulating glucocorticoids, because they can affect development in children. And we're learning something about this in T4. I'm not going to tell you guys more because I can't be ruining all the surprises. Okay, I also threw in a first aid picture summarizing a lot of these components. Don't worry, it's just for your own preview. But the essential thing is hypoglycemia and ghrelin. These are big components in the anterior pituitary release of growth hormone. Somatostatin, okay, somatostatin from the hypothalamus is going to shut this down. Okay, don't think about it in terms of the pancreas. The pancreas somatostatin is only going to deal with the alpha and the beta processes. Okay, don't get it twisted. Okay, now this is why they tell teenagers to sleep. But the problem is the teenagers don't actually want to sleep because we have too much, I don't know, like growth hormone and thyroid stimulating components all running around, which causes difficulty in actually falling asleep. But when you are actually sleeping, you're going to have increased pulsatile nature of growth hormone. Why you need to know this is because around midnight, as well as close to 5 a.m., is when you're going to have like nice sharp spikes of growth hormone. And you have to essentially hit stage 3, stage 4 slow wave sleep. You guys have no idea what I'm talking about. Probably you do, because from you guys remember from your MCAT days. But the slow wave sleep is the point where you're doing your actual deep sleep, and those increased levels of activity at the brain level is going to cause this pulsatile nature from the hypothalamus and, of course, the pituitary level release of growth hormone. So that's why I get plenty of sleep. Okay. And then, of course, like, don't grow old, because like growth hormone goes down and then you stop growing. And then, I don't know, like, life sucks. Okay. Regulation of growth hormone. Okay. Essentially, you need to know is that your somatostatin is going to inhibit the release of growth hormone. The other mechanism is, of course, the negative feedback that you're going to get from the actual released growth hormone, as well as insulin-like growth factor 1. Okay. Thyroid hormone also has a component in this, so keep this in mind. If you have a child with hypothyroidism, right? Let's say this child has an autoimmune condition and shoot, this child isn't growing further, you got to test both the growth hormone as well as the thyroid hormone level, because hypothyroidism is going to have downstream effects on how much GH is actually released and the action of it, because thyroid upregulates a lot of metabolic changes, and those metabolic demands are going to be needed for the actual growth and development of the child. Okay, hypersecretion of growth hormone, 2 components, gigantism and acromegaly. You got to know the differentiating factors between both, because gigantism occurs before the closure of the epiphyseal plate. Epiphyseal plate, if you can recall back to your your MSK days, I'm really like fixated on NB for some reason. You guys will see why. Okay, MSK, you guys covered how the epiphyseal growth plates are still active when you are about to go into puberty, right? And it will subsequently close. When you don't have that, what you're going to have essentially is those increased deposition of collagen at the epiphyseal plate so that the bones become longer, right? When you are actually done with puberty and you have some kind of growth hormone issue, you're going to have acromegaly. And the acromegaly can be explained because of, actually, I don't have a slide on this, but I will explain it properly because acromegaly is only going to make changes on actual changeable structures such as bone density, as well as growth, not vertically, but horizontally, more so like in the width level. So what would you likely see? A great example is Arnold Schwarzenegger, right? He admitted back in the day that he used growth hormones as well as I think a couple of the thyroid stimulating hormones to essentially lead to like greater deposition of muscle growth and so many other things. But you can see the classic presentations of it. He has like he has a square jaw. It's like chiseled because that whole jaw is essentially increasing in size, right? Not in terms of verticality or anything. It's just in terms of width-wise, it's getting bigger. One essential thing to note is if you're seeing it clinically, you're going to see the spacing of the teeth because your teeth are done growing. They're already nestled in your jaw, but as they're coming up, they will just come and place where they're normally meant to be, but the jaw will continue to grow. So you're going to see this nice chiseled jaw as well as like, you know, wide spacing of his teeth. So if you see Arnold Schwarzenegger and you look at a picture of his teeth, you can see the spacing that has occurred. Of course, like he then subsequently went on to change it too, but like, well, that's a different conversation for another day. The other hormone that I told you guys about is prolactin, right? These are the ones that are directly acting. So they're going to cause skin level changes, right? As well as changes to the development of the mammary glands, as well as, you know, if you're talking about your growth hormone, we're talking about your liver as well as your muscle. So things that affect it, somatostatin, right? In terms of negative feedback, and then your GHRH. What is GHRH? Your growth hormone releasing hormone. A mouthful, but essential to know. And then TRH, critical that you guys know is that know that TRH, thyroid releasing hormone, has a positive feedback effect on the growth hormone as well as the prolactin hormone that's subsequently released from the anterior pituitary. Okay, panhypopituitarism. So what are we talking about? This is the issue with a deficiency in all pituitary hormones. So you can have this due to one amazing condition that you wouldn't think about, like in the grand scheme of things, because it's a huge pathological pathway. It's Sheehan syndrome. What the heck is happening with Sheehan syndrome? Remember, when you are pregnant, which I am not, ironically, when you have Sheehan syndrome, the pituitary gets really uncomfortable because a lot of hormones are being secreted in order to, one, deal with the development of development of a fetus inside of you, and then two, you're trying to balance the metabolic demands of the mother and compensate it for when it's going to deal with the baby's development and maturation. Okay. The pituitary gets pretty uncomfortable because the sella turcica can only hold a pituitary to a certain degree. But when you have this kind of increased size and development of the pituitary, there's a lot of blood and oxygen demand to the pituitary. So upon delivery, there is an infarction that can happen. You throw a clot, it goes and starts getting lodged in this highly metabolically demanding place known as the pituitary and shuts everything down. So what would you essentially see? You're going to see basically a global deficiency of all of your pituitary hormones, right? Obviously in children, you'll see like a whole bunch of stuff with dwarfism, hypogonadism, but it's a very simple thing with mothers, right? It's the baby, one fine day, the baby isn't getting milk because the mom can't produce it. Why? Because the prolactin levels just drop, right? That's bad. That's pretty bad. But what you need to know is that in adults, there are three major effects. hypothyroidism, decreased sex hormones, and then decreased glucocorticoids, right? Another great thing to note is a pituitary stalk injury. It's going to result in diabetes insipidus, right? Why? Because it's a global deficiency. You're taking the infundibulum area and the stalk of the pituitary and just snapped it off, right? So you're no longer releasing all this ADH to retain water from your collecting ducts, right? Panhypopituitarism, and then you can have hyperprolactinoma. Why would you have hyperprolactinoma? Because your cells at the anterior pituitary, right, are just straight up spitting out a whole bunch of stuff, right? They don't have a regulatory component because they're no longer connected to the hypothalamus. So what happens is you have to make sure you manage this, one, either surgically, or two, you got to give dopamine analogs to inhibit prolactin. Why do you need to know this? Because dopamine is a great inhibitor of prolactin. One of the drugs you can give is bromocriptine. Bromocriptine, you guys have either heard about it in lecture or subsequently you're going to hear about it in ER, is a dopamine analog. It's also used to treat Parkinson's. Great drug. It's an analog, fantastic, but you have high prolactin levels with panhypopituitarism, correct? Because you have unregulated levels of control of prolactin, right? Because the anterior pituitary can continue to spit out hormones into the blood, and that's going to cause unregulated kind of milk letdown. Functions of prolactin. Main function is breast development and milk production, but not the ejection of milk. What's the actual hormone that deals with the ejection of the milk? It's oxytocin, okay? So it initiates and maintains milk production. A little bit of random fun fact that I want to throw in is that if you guys have heard about the historical kind of usage of wet nurses, you don't need essentially one of the wet nurses to have delivered a kid. You can just do it based off of you can literally manually stimulate the breast tissues in order to release the prolactin from the actual pituitary, leading to the milk that you're seeing subsequently with wet nurses. What you need to know is that a lactating female is going to repress GnRH synthesis. Okay, just to clarify, if you have a deficiency in our pituitary hormones, how would we see too much prolactin? Because you don't have a regulatory component, okay? This is the thing. In the anterior pituitary, the cells that are producing the cells that are there are still connected to the vasculature. Even though you've infarcted the actual infundibular region of the pituitary and the stalk, there's no longer hormones going from the hypothalamic level that are stopping and inhibiting the prolactin cells, okay? That is going to cause unregulation, and they're going to straight up constantly spit out prolactin, okay? I hope that clarified it. Okay. Getting back to this slide, inhibiting of ovulation in females. When a mother gives, birth to a baby, you're going to have high levels of prolactin, as well as, a whole bunch of other hormones. But prolactin is a great hormone to keep in mind because up to 3 months after the actual delivery, it's like a cheap contraceptive because it straight up will mess up your actual cycles, right? Your menstrual cycles, as well as your release of an egg. So that's why something to keep in mind. And it makes sense biologically why that is. Prolactin is going to inhibit it, and you don't want subsequent impregnation of a female, right? So that would cause severe life and harm to the actual mother. So it's a great biological compensatory mechanism. Another thing to note is a hypothyroidism. Due to the elevated levels of TRH, it's going to lead to high levels of prolactin, and that's going to lead to GnRH inhibition, and you're going to have the lack of a cycle, right? You're going to not have a proper release of an egg subsequently into the fallopian tube. So keep that in mind. Once again, up to 3-4 months after delivery. But that being said, as always, an OB-GYN is going to monitor and give subsequent medication if need be. Regulation of prolactin, physiological condition, right? Just to keep in mind, dopamine is going to inhibit prolactin synthesis. So that's why we give dopamine analogs to someone who has prolactinomas, because you don't want them to have overproduction of milk and dopamine is a great inhibitor of it. Okay, thyroid. Okay, thyroid is going to go. Wait, yes, yeah, thyroid. Hypothalamus, right? Your TRH is going to stimulate the anterior pituitary to then subsequently go and increase the prolactin synthesis, right? This can be seen with secondary hypothyroidism, because you're going to have increased levels of TRH, right? Your body's like, wait, where's all my thyroid hormones? There's no thyroid hormones released. So your pituitary is like, let me start spitting out more TRH, trying to stimulate it. It doesn't do a good job, but you're going to have increased levels of prolactin because TRH is one of the stimulating factors. Another thing to keep in mind, estradiol. Okay, estradiol is one of your sex hormones, inhibits dopamine action at the hypothalamic level, as well as sensitizes the TRH releasing factors, which then subsequently leads to increased prolactin. The pathway for it isn't fully understood, so just keep that in mind. What you do need to know is that TRH is going to have effect on increasing prolactin levels. Okay, prolactinomas. This is what I was telling you guys about back in the day. Bitemporal hemianopia, they love this question because it's going to go and mess with the optic nerve in the optic chiasm area. It's going to cause the pituitary to start blowing up and start squishing up against the optic chiasm, leading to the bitemporal. So like on the two templar side, right, of your vision field, you're going to not see anything. You're going to only see everything that's in the middle. Okay. This is the mechanism of action of prolactin. It's a great summary, and you guys can see exactly what hormone is doing what. I'm gonna assume that you guys know it very well. Feel free to ask me questions at the tail end to cover anything else. Posterior pituitary, more big brain energy. Keep that in mind. We're talking about the hypothalamic hypophyseal tract. Keep it straight. Okay. As always, I'm going to bring this back up. SAD, POX, okay? Superoptic nucleus, okay? Break apart the words superoptic nucleus. The optic chiasm is like right here. So superoptic, right above the nucleus, right? Superoptic ADH, right? Versus the paraventricular, right? Paraventricular, you're in the ventricular spaces where CSF is floating around. There is the production of oxytocin and POX, right? That's SAD POX. Oxytocin, really critical for milk letdown. Keep that in mind. Remember, this is derived from the neuroectoderm, because at the end, you got to know that everything that is synthesized here for the posterior pituitary is happening at the hypothalamic level. So if you have any sort of like snapping off of the stalk of the pituitary, all of these hormones aren't going to be able to be released into the actual vasculature. Okay. Remember, posterior pituitary only stores it. It's like at the pars nervosa. Okay, mechanism of action. I'm a firm believer of not memorizing anything. So I want to give you guys the full pathway. First thing you need to know is that the ADH goes and acts on the ADH receptors in the collecting duct. Okay, in the collecting duct, it's going to go attach, and then it's going to activate the adenylate cyclase pathway. Right? Remember, GS. Cyclic AMP gets elevated, pKa gets going, and pKa is then subsequently going to help put out more of the aquaporins. Aquaporins are going to help you. One, aquaporin 2 is what you need to remember. This is like a throwback to CPR. Water is going to be brought into the cell and eventually subsequently put into the interstitial space and the vasculature so that you can concentrate your urine. Okay. If you don't have this, you can have either two forms, diabetes insipidus of the brain kind or the neurogenic kind. So keep that in mind. Also, for my semi-alcoholic friends, ethanol goes and inhibits the hypothalamic component of this. So that's why you got to pee all the time if you drink, because ADH is inhibited and you're subsequently peeing out more water, right? Your urine's more diluted. So that's the mechanism of action, if anyone wanted to know, of why you got to run to the bathroom every 5 seconds. Blood osmolarity is going to be a big contributing factor of it, as well as angiotensin 2, blood pressure, and blood volume. Okay. Yeah. Remember, There are osmoreceptors as well as baroreceptors. You guys are going to learn this subsequently of the carotid bodies that are there. Not right now, that's an NB problem, but keep that in mind that osmoreceptors are modulating, they're constantly keeping an eye on your osmolarity of the blood, whereas your blood pressure, right? If your blood volume changes in any kind of capacity, as well as how much is being pumped out, your carotid bodies are like, how about like we make sure our blood is thick enough or it's more dilute so that we can subsequently have more ejection and bring you back to normal. So keep that in mind. That is going to be a bigger systemic thing that we're going to cover. Central, okay. Whenever you think about central, think brain. So central brain, it's decreased levels of ADH. Why? You either have a lesion, you have some kind of damage. Keep that straight. You treat it with exogenous ADH. The analog is DAVP. Don't worry about it. You just need to know you treat with ADH. Nephrogenic, right? It's because you're going to have a whole bunch of circulating levels of ADH, but the receptor level damage is at the actual kidneys. Nephrogenic, okay? Kidneys. GS proteins or adenylate cyclase is messed up. You can have hypercalcemia. Drugs such as lithium can cause this. Lithium, you're going to cover in NB3, is used to treat a lot of different psychological disorders. So don't get it twisted. This is like a big concept, but you're going to learn more about it in pathology. So what does this look like? With both central and nephrogenic diabetes insipidus, you have essentially very, very dilute urine. You got to concentrate your urine. So what you need to do is, one, administer in order to find out ADH, exogenous ADH. If it's central diabetes insipidus, your urine's going to get concentrated because you've now given exogenous ADH, and that's going to help you put in those aquaporins to bring water in, concentrating your urine. Your urine osmolarity is going to go up, okay? Now, if it's nephrogenic, you're kind of screwed because you can give it as much ADH you want. It's not going to do anything because those receptors aren't working. It's not going to bind. It's not going to make those subsequent changes in order to put these aquaporins out. Problematic. So you got to treat it and keep it kind of like systemically. That's something we're going to cover later. Okay. Syndrome of inappropriate ADH, SIADH. So something to keep in mind, a little pathology to keep straight, is that oat cell carcinoma, right, of the lung can stimulate excess ADH, right? That's why it's inappropriate levels of ADH. What happens? You have too much ADH, you have too much retention, it's going to have cardiac issues, you're going to have increased urine concentration, not always the good thing, and then decreased serum osmolarity. Your blood is too liquidy, right? Like there's too much water in it. It's going to have downstream effects, cardiac issues, damages to the tissues, so many things. Treatment is going to be ADH antagonist, doxycycline, as well as water restriction. So you're going to tell the patient, you're not getting any water today. You got to stay a little dehydrated. Stay thirsty, my friends. So, okay, here's the nice summary of all of it so you guys can see in a visual form. Ethanol is going to inhibit, right, the supraoptic and paraventricular. So it's going to go through, it's going to have kidney level changes, it's going to have vascular level changes, and then pituitary level changes in terms of what is released. So this is more of a systemic picture. I wanted to give you guys this just so that you guys, for my visual learners out there, know what's up. Okay, paraventricular oxytocin, okay. Hella important. What does oxytocin do? You guys know this. You guys have covered a little bit of repro already. Uterine contractions is one of the more important things to keep in mind. A whole bunch of oxytocin gets spit out, okay? Another component is the mammillary glands. When you have delivered, essentially, is the first letdown. The passage of the first milk is really critical because, one, you got to feed the baby as soon as it comes out because it's going to start crying and you got to shut it up for a while. The second thing is it helps with the central nervous system as well as the psychological component of bonding with the baby. Okay, so that's why, like, a lot of parents, if they don't have subsequent oxytocin release, it's hard for the mother and the child to bond properly. There's a huge psychological component as well as a physiological component with this. Okay, so this is what they kind of showed you here. Nursing the baby as well as pressure against the cervix is going to cause subsequent oxytocin release from the posterior pituitary. How about this? I am going to give you guys, since we've been going for a good chunk of time, I'm going to give you guys a little break before we cover the synthesis of amino acids, because this is a very chunky section of this review, and I want you guys to know it's solid for the exam because they love asking questions about this. So I'm going to give you guys a 5-minute break, and in the meantime, I will be back. Can you guys see my screen okay? Okay, let's do this. Awesome. So synthesis of amino acids. This one is a big component and they like to test this a lot. So synthesis of hormones and the derivative kind of components. Let's go over it. It's more biochem, but it's not bad. Okay. I'm going to make your guys' life super easy. Memorize all of these amino acids, not right now, but for DM. Okay. The essential ones you do need to know are phenylalanine and tyrosine, as well as tryptophan. Everything else, that's another day's problem, okay? You guys need to know the entire pathway for the phenylalanine and tryptophan, like the back of your hand. Everything else, you're pretty much good, okay? So let's cover this. Keep this in mind. Phenylalanine deficiency, right? Like whether it's caused by PKU, right? Like you can't have more phenylalanine, or like you got to supplement with tyrosine. Those are things that they're going to ask you in DM. Don't get it tripped up right now. I just want to give you guys a big picture of it, so that you guys are good for your review. Phenylalanine to tyrosine, it's going to be phenylalanine hydroxylase. You got to know the cofactor that is needed, which is the tetrahydrobiopterine BH4. We just call it BH4 so that we don't like get traumatized every single time saying it. Tyrosine to dopa is important because tyrosine hydroxylase is critical. Now, dopa to dopamine is dopa decarboxylase. Now, this is a really good one because there is an exogenous version of not exogenous, but like the vasculature level of dopamine carboxylase, as well as the brain level dopamine decarboxylase. For Parkinson's disease, you're going to give L-DOPA, right? Because L-DOPA can cross the blood-brain barrier. Dopamine cannot. This is something you're going to learn in NB, but it's also something that they like to ask in the question stem to give you guys hints as to what type of hormone they're talking about. Dopamine requires PLP, okay? Vitamin B6, you're going to learn all these vitamins all over again. You need to know every single vitamin under the sun for obvious reasons in DM. Dopamine to norepinephrine is critical because this is one of the steps that happens in both the adrenals as well as the subsequent one of getting norepinephrine to epinephrine. It needs dopamine beta hydroxylase and then phenylethylamine and methyltransferase. I can't pronounce these things for my dear life, but what you need to know is that vitamin C is required for this, as well as SAM, right? These two things are very essential because they can ask you a question on vitamin C deficiency in terms of like bleeding gums and all sorts of crazy stuff with that. So that could be a quick way of asking a very basic level question of dopamine to norepi via this pathway, okay? SAM is going to be covered subsequently later, but just know that SAM is involved with the norepi to epi because that's a big conversion step that happens in, of course, the adrenal medulla, okay? Parkinson's, something that I'm very near and dear and researched heavy on. Neurodegenerative condition, you're going to learn the entire mechanism of action. But as of right now, you got to make sure you learn it. That Parkinson's, you're going to give dopamine analogs, which are going to be like bromocriptine, L-DOPA, Cinemat. All these things are critical in the actual treatment and the management of Parkinson's disease. Okay. Okay, very simple. Pheochromocytoma, what are you going to have elevated of? You're going to have your metanephrines and normetanephrines. It's essentially a derivative of epinephrine and norepi, so it's not too hard to like remember. And then your vanilla mandelic acids. Okay, what you do is someone has pheochromocytoma, you can't just ask them to pee once because these are episodic issues with pheochromocytoma. It's not like they're constantly agitated and panicky. It's like it'll come in waves. So what you do is a 24-hour urine collection of the patient, and you're going to see increased levels and spikes of the VMAs through and through that 24 hours. Okay. which you shouldn't have. Like normally, no one should be that stressed unless you're taking an SGU exam, okay? From each module to module, you'll see why it becomes a thing. Pheochromocytoma, I told you guys, right? The 5 Ps, if you can remember it, you're essentially set. Headaches, palpitations, intense anxiety, basically an SGU exam, and then hypertensive. So just essentially you're set for, locking up with your exam soft. Now, dopamine is really important because what are you going to likely have with a Parkinson's patient? You're going to have less dopamine circulating through and through. You're going to have decreased levels of HVA. Just a little clinical correlate, but they love to ask about it regardless as a good way. You don't need to, anything that's crossed out, you don't need to know. COMT and MAO are important in the breakdown of the dopamine metabolites. All catecholamines use MAO and COMT because remember, they're all from the same biochemical pathway, right? Chemical structure-wise, they are the exact same. Now, the only exception is serotonin. Since it's not a catecholamine, it only uses MAO, right? Sometimes we can give MAO inhibitors in order to treat people with depression, anxiety, and all sorts of psychological components to increase your serotonin levels and make them feel good about, life. Okay, moving right along. Tryptophan. Tryptophan, right, is one of the essential amino acids that you have to memorize. Serotonin is synthesized in the gut, platelets, as well as CNS. Why? Because the gut has a huge involvement when you're getting to DM with serotonin. Central nervous system makes so much sense because you need serotonin. It's the somewhat feel good, content, happy hormone. Okay, tryptophan, right, gets converted via tryptophan hydroxylase into 5-hydroxytryptophan. Essential that you need to know that. They like to ask any of these steps. BH4. If you have a BH4 deficiency, you got to make sure that you remember that both pathways are affected, both the phenylalanine as well as the tryptophan pathway, in order to create these hormones. What happens is you get your 5-hydroxytryptophan then getting converted to 5-HTT, which is the 5-hydroxytryptamine, which is serotonin. Eventually, when you guys are getting into NB, you're going to get some modification of this further via this whole kind of cascading pathway in that you create melatonin due to decreased blue light exposure. So don't stare at your phones before going to bed, something that I don't follow on a daily basis. Okay, 5-hydroxytryptamine, like I said, what is the metabolite that's going to be found in the urine if you have a deficiency or an excess levels of serotonin? You need to know that it's 5-HIAA. Now, how are they going to ask you guys this? Okay, how are they going to ask you guys this? Is because of carcinoid syndrome. APOD cells. I swear, if you guys remember anything for carcinoid syndrome, it's APOD cells. They love asking this. Cutaneous flushing accompanied by sweating because you're going to get sympathetic activation. You're going to have increased diarrhea because gastric motility is involved in the serotonin production at the local site, and then bronchospasms. What are you going to find in the 24-hour urine collection? Increased 5-HIAA, okay, which is the metabolite. And they can straight up just give you all of this info and then ask you what is the converting component. And you're like, MAO, that's all I need to know, and then walk away and get your point. Cool. Melatonin, super important. Don't take it exogenously in high levels because it messes up your sleep cycle, but it's still important. 5-hydroxytryptamine, serotonin, gets converted and modified further in the pineal gland. Remember the buzzword for the pineal gland, third ventricular space. It's a diencephalic component and diencephalon, not diencephalic, diencephalon, and it is the corpora ironacea, which is the brain sand. If you guys are familiar with a really old song, Mr. Sandman, that's how I remember the pineal gland. Okay. It also makes sense because, like, I don't know. Okay, never mind that. I could go on a tangent on that. Tetrahydrobiopterine deficiency, what gets messed up? Remember, a deficiency of this, whether it's the synthesis or the actual enzyme, it can cause phenylalanemia because you're just having a whole bunch of phenylalanine just sitting there. They don't know what to do with themselves, and they're going to cause downstream effects on your system. You're going to have decreased levels of neurotransmitters, both catecholamine and serotonin. Patient's going to be sad, depressed, and not having a good time, right? Makes sense, basically med school. Okay, management includes the addition of dietary tetrahydrobiopterin, right? As well as if you have like, let's say like you have PKU, you can add tetrahydrobiopterin as well as you could restrict phenylalanine in order to make sure that the patient is okay. You're gonna learn the mechanism of action of PKU more than you'd like to know in DM. Okay, now we're getting to the thyroid. Thyroid is a bit of a pain, but all you need to know is that there is essentially four components. There's the TRH, the thyrotrophin releasing hormone. There's the TSH, which is the thyroid stimulating hormone coming from the pituitary, where anterior pituitary, make sure you guys know those hormones straight out. And then you can have iodination and coupling done with thyroperoxidase. Know that enzyme, thyroperoxidase, very important. And then T4 is the circulating, biologically less active version of thyroid hormone, whereas the T3 is like, it gets changed from T4 to T3 at the actual tissue level. So that's going to regulate activity of the thyroid hormones at the tissue level and causes upregulation of metabolic changes and so on and so forth. Okay, back in the day, you know, we didn't have iodine in our salts. For those who are in the United States of America, we didn't have that. A bunch of people got issues, and then like, I don't know, the FDA was like, yo, we got to put some salt with iodine, and then like this happened. So now we don't have too much of thyroid level issues. The reason why we need iodine is because iodination is a big process, right? You got to trap the iodine, you're going to iodinate it, you're going to couple it, and then with the actual tyrosine side chains, release the thyroid hormones. You're going to then deiodinate, right? Because you got to convert from T4 to T3. Okay. They really like this one because they like to ask about the subsequent components. I'll explain to you guys when we get to that picture. It's the 5' deiodinase. They like this. I think Sobering told us we got to memorize that one. And then deactivation, T4 may be inactivated by the conversion of the reverse T3 form, and that's the 5-deiodinase. It's a different enzyme to the 5' deiodinase. I'll show you guys that in a minute. T3 acts via gene regulation. Okay, gene regulation, very important because you got to think about the huge downstream cascade rather than just like, oh, like T3 just goes and messes around with the cell. No, it's going to cause, it's very similar to the steroid level changes seen with other hormones, right? Like, you know, your steroid derived, cholesterol derived hormones. Okay. Okay. You know, goiters, they're kind of toxic. Just kidding. Iodine, that was a terrible joke. Iodine deficiency is a nutritionally derived component. You can also have like toxic goiter due to like, you can radiate the iodine, which then causes like thyroid level changes and damage, and that can be hella bad. One of the ways radiation does that is oof, oof. Maternal iodine deficiency is really bad. That's why most of our salts that we get is already iodinated. So you can have congenital hypothyroidism. Now, what did we say that hypothyroidism also is involved in is the growth and development. So your growth hormones are also messed up, right? During fetal and infant development, they're going to have a whole series of downstream effects. Intellectual disability, hearing loss, seizures, short stature, not good. Okay, Graves' disease. Really important that you guys know this. Remember, this is hyperthyroidism, right? This is the exophthalmos that everyone like sees, and like you got to lock up with ExamSoft. That's how I look during my ExamSoft monitoring file gets uploaded. Graves' disease is really important because this hyperthyroidism is caused by antibodies, right? Typically IgG, because that's the one that's circulating around causing problems. And it regulates excessive production or the overproduction of thyroid hormones, AKA they're going to lose weight, they're going to perspirate, they're going to like have like tachycardia, and they're going to have protruding eyes because the increased deposition of gags in the whole conjunctiva area. And then they're all blown up. Okay. Hyperthyroidism can also happen from overconsumption of iodine. Keep that in mind. Most of the time, no one's chugging down iodine directly. They just might have like an excess amount of salt intake too, because most of the salts that we're having is iodinated. Okay, steroid hormone metabolism. Don't take steroids, folks. It's bad. And I'll explain why in a minute. Okay. What happens is that steroids are cholesterol derived, right? So steroid hormones are lipids essentially by nature. What happens is they go on target cells and they cause intercellular changes at the receptors in the cytosol or the nucleus. They bind to these, and then there are actual specific sites in our DNA that's called steroid receptor sites that straight up bind these complexes and upregulate transcription and then eventually translation of unique proteins, as well as enzymes, etc. Cool. We're getting back to the adrenals because this is where the good chunk of all of these steroid synthesis happens. As always, remember your glucocorticoids, which is your cortisol, mineralocorticoids, aldosterone, and the weak androgens. Remember the mnemonic, sweeter as you go deeper, because you're talking about salt, you're talking about sugar, and then sex, okay? That's just a quick way to keep it straight. Your testes create androgens. Those are your testosterone. Your ovaries, estrogen. You guys know that very well by now. And this, your corpus luteum, this dude hemorrhages and then just changes and then starts spitting out progesterone. Okay, this dude is straight up a gangster. But like it also explains why the mechanism of action of the whole menarche cycle is the way it is. Okay, in which of the zones do most of these get synthesized? Okay, and the regulation of it is really critical. They love asking questions about this. Receptors for both ACTH and angiotensin. Okay, this is a weird one. They do have receptors for ACTH, but when they ask you, it's always going to be the whole renin angiotensin for aldosterone. Okay, do not, if they give you a question stem, do not put ACTH because they don't like it. Okay, it's going to be marked wrong. Put angiotensin, renin pathway when you're talking about the glomerulosa. Whereas the cortisol and some DHA and the androgens, those are going to be your primary ACTH because it makes sense. Fun fact, when you wake up in the morning and you have a nice spike of cortisol, don't chug coffee. You're already stressed out, okay? I mean, we all do anyway, but like there's a reason why our cortisol spikes in the morning so that we can increase blood glucose levels and subsequently wake up. So the action of it is a increase like pulsatile nature of ACTH coming from the pituitary that's going to act on the fascicular region and lead to the subsequent spike that helps you wake up and feel refreshed in the morning. Something that I haven't done or felt refreshed in multiple weeks after starting term 4. Okay, how is cortisol synthesized? Okay, they love this. I don't know why. It's a star thing, okay? Just like look at the little frog, look at Kermit. He's just saying, look, you got to know star, okay? What happens is cholesterol is sequestered in pockets, right? And it has to be subsequently brought into the mitochondria. You're going to learn the mechanism of action of this, but star is a primary regulator of bringing that said cholesterol that is synthesized at the actual adipocytes into the mitochondria. Because remember, cholesterol is chunky. Like you got to be very selective as to what you bring into the mitochondria because there's a lot of downstream implications. Remember, once you are in the mitochondria, you got to convert it to cholesterol to pregnenolone, and that's done by P450 cytochrome complex, and that's going to be something you're going to learn very well. Okay, the primary regulator that brings it up is ACTH. It makes sense because what's happening? What are you subsequently making? Cortisol and your androgens. Fun fact, that's why you have like a spike of testosterone and your weak androgens in the morning. Look, the more you know. Okay, renin, angiotensin, aldosterone system. What you need to know is that renin is released from the JGJ or juxtaglomerular apparatus. I said that way too fast. Renin is released. It then goes to the angiotensinogen. Remember, tensinogen is an enzyme that has not yet been properly converted into the active form. It turns into angiotensin. You're going to learn the mechanism of action in angiotensin T4. That's going to meet up with ACE in the lungs and say, hey, let's get converted. And ACE converts angiotensin to angiotensinogen 2. That goes and acts directly on the zona glomerulosa and subsequently release aldosterone. What happens subsequently with aldosterone? Aldosterone is going to go and act on the absorption of sodium, right? Because you're trying to increase your blood volume by bringing in salt as well as water in that same process. You're going to start spitting out potassium. This can be a good thing and a bad thing. Angiotensin 2 is also important because angiotensin 2 is going to go and deal with blood vessels and stimulating vasoconstriction. All of these are very important. You guys learned it in CPR 2. And the whole pathway is shown here, okay? What you need to know for now is that cortisol is going to activate gluconeogenesis and all of the subsequent changes to wake you up, right? It makes sense. You have a nice spike in the morning. Yeah, you're going to want sugar in your blood just to like pep yourself up and, you know, get out of bed. The next thing is you're going to have tag degradation. That's why you're going to have a little bit of spike in the amount of cholesterol, lipids, and other stuff floating in your blood in the morning. Skeletal muscle, it's going to cause protein degradation, release of amino acid, but don't get it twisted. That's only if you have high levels of cortisol. Fun fact, if you have high levels of cortisol, like all your muscles will start getting like smaller and smaller, but like your central part of your body is going to get a little chunky. So that's why that increased stress isn't good for like adipose deposition in like the trunk area. So try to relax once in a while. Your beach body will thank you in like, I swear, like 5 years or something. Now, this is more relevant for us T4s. There is anti-inflammatory properties with cortisol. This is why we give glucocorticoids often with a lot of drugs for transplants and all sorts of things, because it inhibits phospholipase A2 and the reduction synthesis of eicosanoids, right? And these are going to be important when you guys are talking about inflammation and stuff more along the term. So you're not right now, but like later. Okay, what else do you need to know? Aromatases, okay? Aromatases are really important. Don't get it twisted. It's one of the ways we take those weak androgens and convert it into its active form, such as estrogen or testosterone, so many other things. So two things to keep in mind, they can give you both names, CYP19 or aromatase. So that's critical. And then your extraadrenal tissues, they also have 17-beta hydroxysteroid DH3. This is a mouthful. They typically just say 17-beta hydroxysteroid dehydrogenase, and they don't ask the 3 part. That helps convert everything into the active testosterone form. And you guys know this because you can see how the organ, the sex hormone or weak sex hormone deals with the initial development of the baby's reproductive organs early on. Okay, cortisol synthesis is reduced in 2 essential pathologies or issues: congenital adrenal hyperplasia. So you're like, wait, what? Why is the hyperplasia? I'll explain. One enzyme in the cortisol synthesis is deficient. So what happens, why are you like, oh, it's hyperplasia, there's more cells? It's because one type of enzyme has taken over when the other is deficient. So that's the mechanism of action when you're kind of going through this process. Addison's disease is the other one. That's like primary, I think like, yeah, I'll explain that primary component in a bit. Atrophy of the adrenal cortex, all corticoids are low. It's like everything. You're going to feel sad. You're going to feel low. You're not going to feel energized. There's a lot of different components with Addison's disease. And then cortisol synthesis is increased, right? That's the other kind of major category. It can either be with 2 things, either with Cushing's syndrome or Cushing's disease, right? Disease is more central issue, right? It's from the pituitary, whereas syndrome is actually at the adrenal cortex. Okay, hypercortisolism, and we'll explain that in a bit. Okay, this is a little crazy, but most of the congenital adrenal hyperplasia is because of the autosomal recessive diseases kind of category. So if they ever ask you like a sobering level question of like, oh, what is CAH typically in terms of inheritance pattern? Autosomal recessive. They're not going to ask you a Punnett square. I swear to God, if they do, write a 5-page manifesto. Okay, low levels of cortisol reduction that inhibits the feedback of ACTH and leads to overstimulation of adrenal cortex. And I'm going to explain to you guys a very simple way of getting all of these questions right without even having to memorize all of these subsequent names. Okay. This was put together by our near and dear friend Brady, very smarticle particle, and I'm going to explain to you guys why you guys need to know this entire pathway in detail, because it's going to help you a lot. So first thing, cholesterol to pregnenolone is the critical one that people often forget. It's the deficiency of CYP11A, okay? That's everything's down. You're not making anything. You're just going to have a whole bunch of circulating cholesterol levels because you don't know what to do with it. That's very, very, like that's hardly seen. But the subsequent ones on the CYP17, 21, and 11B are the ones that are often asked about, Okay, that's because they're very clinically relevant and the manifestations are very obvious. Okay, let's do this kind of simple mechanism. Okay, when you see a number that is a deficiency with the 17 hydroxylase, like the one, whenever you're seeing the one, it's elevation. Okay, if you see a one, and as long as you make this little table and test yourself over and over again, it's going to be very simple. I swear I did it. I thought it was like the hardest thing, but now I could close my eyes and probably recite out. I said 17 hydroxylase deficiency without any issue. 17 hydroxylase deficiency is going to cause increased blood pressure. Blood pressure is the first thing you want to focus in on. Okay. No one really cares about the androgens because androgens are minor, right? But blood pressure is going to be critical. Okay. One, blood pressure is going to be elevated with 17 hydroxylase deficiency. And two, right, the 17 hydrogenase is going to be decreased, right? So you're going to have decreased androgens floating around. Increased BP, decreased androgens. 21 hydroxylase deficiency, right? 2 comes first, right? We don't have a 1 right away. So what are you going to see elevated is blood pressure is going to be normal, but the androgens are going to be in excess. 3, 11 hydroxylase. This is the major one. It presents with both. You're going to have increased blood pressure as well as increased androgens. And clinically, these are significant, okay? Let's kind of explain this. Remember your basic biochemistry, essentially not even biochemistry, your chemistry, okay? When you have a deficiency of an enzyme, right, a pathway gets shut down. Let's start with 17. So if 17 gets shut down, both of these are gone, okay? There's only one location where everything can go, right? You have a bunch of substrates, you have no products. Like what? You can't go down the DHEA androgen pathways, right? You can't get into cortisol either. So let me explain this in a very, like, if you need to not learn it based off of the trick, learn it this way. CYP17 shuts down, right? There's no CYP17. The only pathway you can take is going from cholesterol to aldosterone. What does aldosterone do? Increase your blood volume, right? Because remember, aldosterone is going to suck up all that sodium and the water subsequently. You're going to be hypertensive. You're going to have heart level issues, and it makes sense. Now, let's do 21, right? 21 is shut down. 21, like these highways are shut down. There's nowhere you can go. So all you have is going from pregnenolone to your androgens. That's all you got. The patient's going to have decreased blood pressure. They're going to have so much androgens floating around because all this pregnenolone, they don't know what to do with themselves other than to get converted into DHEA and then androstenedione, which is then going to be converted to via aromatase to the subsequent products that you need. So that's why you're going to have elevated levels of that. Now, this one is a little bit more tricky. CYP11B1, when you have a deficiency of that, everything gets shut down. But remember, CYP11B1 or B2 can have aldosterone-like presentations because of 11-deoxycorticosterone and corticosterone. These are both biologically active and they're going to do somewhat of a similar function as aldosterone. Now, I've explained this entire highway. It's like the map of California. There's too many highways, everything's confusing. But if you step back and you run through these highways one by one, it's going to explain why you're having the presentations the way they are. Okay, they will keep it very obvious during the exam. They don't like to trick you guys with these. If there is subsequent questions, I will happily go over this again because I know people need like multiple passes through this material. Okay. Now, CYP21A. Okay, this is the entire pathway for all of my biochemically active, interested friends. This is the entire pathway outlined by each zone, as well as the enzymes involved. I've boxed the enzymes and given you the common names for them instead of the full names so that during the SGU exams, you guys are going to be fine. As always, CYP19 is aromatase. That's the one that often people forget, okay? And that takes your weak, androgens and then converts it to the subsequent products that you need to go and activate it. So testosterone, estradiol, critical thing to keep in mind. Okay, here's the first aid picture. They're going to give you these general kind of factors. Make sure you break it apart. For males, ambiguous genitalia, undescended testes. Why? because remember, you have decreased androstenedione. You have weak androgens that are deficient because that helps distinguish and change your reproductive organs to then become either male or female, biologically speaking. When you have in females, you're going to have the lack of secondary sexual development, because remember, androstenediones are essentially hormones that are going to be turned into testosterone, and females don't really need testosterone in high levels. They're going to have proper sexual development initially, and then secondary sexual development, hair growth, and all those things. Those are going to be developmentally challenged. When you're talking about your 21, most common, right? 21, if you see 21, you should be like, okay, yes, most common, because it's going to cause in infancy salt wasting, right? Because remember, we're talking about your increased renin activity, increase 17-hydroxyprogesterone, because there's a whole bunch of it. What is virilization? It's the inability to properly sexually mature, that to produce the sufficient progenies that you need, like at the biological level. 11-beta hydroxylase is going to have decreased aldosterone, and 11-deoxycorticosterone is going to be elevated, right? Remember, 11, so that's 2 ones. So what goes up? Your blood pressure goes up, as well as your subsequent androgens, right? You can see that here. And a little minor note, 11-dehydroxy deficiency, it's going to be a minor increase in blood pressure, because remember, these products, 11-deoxycorticosterone or the corticosterone, are not as good as aldosterone. They're good. They're like the B players. They're not like the 18 players like aldosterone. Just keep that in mind. Okay, let's look at the actual disorders. Cushing's syndrome, okay? It's going to present with hypercortisolism, right? Most of the times, keep that in mind. This is an actual issue with the fasciculata, right? That's the biggest portion of the adrenal cortex. Whereas Cushing's disease, your pituitary is just spitting out ACTH like nobody's business. Keep that in mind. What are you going to have in terms of blood compositions? Glucose is going to be elevated, because remember, cortisol is going to try to increase your blood glucose level. Gluconeogenesis is upregulated. Normal to high epinephrine. Why does that make sense? Because ACTH is another thing that, your growth hormones and your cortisols and all those things also deal with sympathetic activation. Your epinephrine is going to be something that's there. Increased synthesis in the adrenals, keep that in mind, of the androgens, okay? Addison's disease, this one's good. If you see a person who's bronzed, like they're like, I don't know, one point they were white in their life and all of a sudden they look like they got a wicked tan. No, they didn't just hang out in Grand Anne's Beach. Like they just they decided to have Addison's disease. No, they didn't decide, they just had Addison's disease, okay? Decreased synthesis of all corticoids, right? Everything's shut down, everything's low, they are tired, they're fatigued, they're bronzing of the gums because of your POMC. Can someone tell me what POMC means? It's pro-opiomelanocorticoids. Those get subsequently converted into melanin, and they also have effects on your ability to deal with pain. So just something to note minorly. Okay, all of your congenital adrenal hyperplasia, you guys know these in terms of what is happening. If you have, this one is very, 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 very low in terms of what is tested. If you have overall 3-hydroxysteroid dehydrogenase deficiency, this is one of the major ones. You're gonna have low fasting, low of everything, and then high DHEA in the adrenals. Because why? Let's take a peek. This enzyme is deficient. Only thing that's going to be left that it can go through in this pathway from pregnenolone is DHEA. That's all it can do. It can't even get converted to androstenedione and then subsequently into aromatase. So just keep that in mind. It's very often not asked about, but a good one to remember because it's an exception. Going back, 17, 21, and 11B. Most common they're going to ask you about is 21. If you have no idea what the heck is happening with this and you have to guess, go with 21. But 17, you guys should be able to explain the mechanism, and 11B deficiency, you should also be able to explain the mechanism. A little minor note that I want to emphasize just because it's important. This 11B1 and then 11B2, more specifically 11B2, it's dependent on your renin-angiotensin pathway. This gets upregulated when your body's like, hey, shoot, we got to increase our blood glucose sorry, if we got to increase our blood volume level. So why don't we activate our wonderful CYP11B2 and increase the synthesis of aldosterone so we can bring back in our essential water as well as sodium. Okay. Going back. Okay. This one is simple. Brady and Lindsay are going to cover it tomorrow. Just keep that in mind. I don't want to hammer this home too much. Important, GnRH is coming from the hypothalamus, and then it goes and acts on the into your LH and FSH locations in the anterior pituitary, in the adenohypophysis. LH and FSH are going to be spit out. LH is going to go to the Leydig cells. Make sure you guys know your Leydig cells from your Sertoli in terms of what is produced. Leydig is going to do testosterone, Sertoli, spermatogenesis, critical. Okay. For your females, theca cells, testosterone, and this is going to be a little bit more complex. Brady and Lindsay are going to cover tomorrow. Testosterone to estradiol and the conversion and the subsequent changes from each stage of the cycle is going to be very dependent. Okay. Contains aromatase. Okay. The granulosa cells contain aromatase. Why? Because remember, your body is still producing these weak androgens. Those androgens have to be converted into the proper form of estradiol, and that estradiol will then go and have downstream effects on the brain level. Okay. Cortisol synthesis is reduced in congenital adrenal hyperplasia, Addison's disease, as well as Cushing's syndrome when you're increasing with the cortisol synthesis. Okay, so major categories, keep that in mind. Addison's, okay, bronzing of the skin. If you see someone tannin, it's the pro-opio melanocytes. Straight off the bat, very buzzword heavy. Melanocytes upregulate the production of melanin, and they're bronzed out, right? They were white at one point. These are their brothers and sisters, sorry, not sisters. And now they're all bronzed out. I don't know why, but like it just do be like that because of the POMC. Failure to thrive, weight loss, muscle weakness, salt craving, thinning of axillary pubic hair in some females, and then abdominal pain. So this is the mechanism of action. POMC, MSH, right? It stimulates the melanocytes, increases melanin production. The melanin gets they've been deposited into the skin more evenly, and that's going to lead to the bronzing that you're going to see. There's also a POMC. It's one of the minor pathways of beta endorphins. That's going to deal with your pain regulatory components, not needed to know for this exam. Okay. Please, for the love of God, make sure you guys know Cushing's syndrome versus Cushing's disease, because the syndrome is adrenal gland issue, low ACTH, because your body's like, dude, you're producing too much of your cortisols. Like, you got to take it easy. Whereas Cushing's disease is like, yo, I'm going to spit out too much ACTH and overstimulate your cortisol production. Got to know that very well, as well as the zone that is likely affected. Okay, patients, buzzword heavy, this fatty deposition in the shoulders as well as the back. They have like a moon faces, right? Like I don't know, I don't see the moon faces, but like they have a round face. They have rapid weight gain, central obesity, right? Their arms are going to be super thin because like cortisol starts breaking down muscles in the periphery in order to fuel you better with amino acids and other stuff. So everything's going to start getting deposited in the central aspect of you. Pink purple striae, that's what they call it, like these stretch marks. They're not like your regular stretch marks. Keep that in mind. And you're going to have hirsutism early. And sometimes you're going to have thinning of the hair too. Thin arms and legs, very, very muscle degradation heavy, elevated blood glucose, so on and so forth. Okay. Of course, reduce inflammatory response, because remember, your cortisol is something that we want to make sure that is active so that you are not inflamed. We also give exogenous corticoids in order to treat a lot of things. Adrenals, very simple. Okay, aldosterone, cortisols, and epinephrine, right? You're going to run through this list and you guys are going to know exactly what you need to put when exam day rolls around. Regulated by angiotensin 2 and potassium. Potassium is the one that a lot of people forget. Angiotensin 2 is going to upregulate CYP11B2. Keep that in mind. Then your ACTH is going to be your cortisols primarily, and your androgens, weak androgens, FYI. Epinephrine, norepi, sympathetic control. Remember, nicotinic, neuronal, sympathetic innervation to the medulla, leading to the subsequent release from those neural crest cells, embryological origin, and the release of epinephrine, norepinephrine, okay? What are they going to ask you? Chromaffin cells, like all those things? No, that was very T1. They're going to really keep it very simple with the amount of hormone that's released with like pheochromocytoma or some kind of issue with your aldosterone and cortisol levels. Stress and the role of cortisol. Okay, cortisol, you're going to see that nice spike when you wake up. But if you have chronic stress, it's going to be something that's going to be high. And that's bad because it can lead to a lot of the things that you see with prolonged cortisol stress. Why do we need to know this? Because ACTH secretes a large amount of pre-pro hormones. Remember, pre-pro hormones are basically like they're about to be released and act on something else to release the subsequent hormones. Your pro-opiomelanocytes, from the ACTH perspective, if something happens at the adrenal level and ACTH doesn't know what to do with it, it's going to start going other pathways via the pro-opiomelanocyte pathway. Okay, ACTH is the main physiological factor. Alpha MSH is contained in the sequence of ACTH. If you lose something along the way, it's going to go and start activating other pathways. In physiological range, alpha MSH is not significant. No one really cares about it unless you have some pathology. Excess ACTH secretion results in hyperpigmentation, which you guys know as Addison's disease, because one of the minor pathways is the conversion of POMCs at the melanocyte levels into melanin and then subsequent deposition. Okay, as always, I just want to emphasize this. The ones that are red, boxed in, that's the one you guys need to know. Hypotension, hypovolemia, what's going to be activated? Renin, right? That's at the kidney level, right? Same thing with hyponatremia, increase with sympathetic tone via beta-1 receptors. That's for us T4s who are stressed out about that. And then extracellular fluids are going to do the opposite, right? They're going to tell the body like, hey, dude, you got too much volume floating around. Let's bring it back down. So that's going to downregulate a lot of things. And the renin-angiotensin pathway gets shut down via this pathway as well. Hyperaldosteronism, critical to remember, increased secretion of aldosterone from the adrenal cortex. As always, aldosterone is going to do what, right? Hypertension, decrease to normal potassium, metabolic alkalosis. No one really gets this initially because everyone's like, why do we have potassium? Potassium is critical because it's bound to albumin, and when you have like less of albumin and potentially potassium, it's going to cause an influx of your hydrogen ions into the cells, and that's going to cause more alkalosis because there's more of bases floating in your blood. So keep that in mind. We're going to cover, that's going to be covered more in DM2. So just keeping a little bit of a head preview. Primary, also known as Conn syndrome. Whenever I'm telling you guys about a primary, it's a issue at the tissue level or at the organ or etc. It can be due to an adrenal adenoma, right? Or some kind of issue of hyperplasia at the glomerulosa. Whole bunch of aldosterone and a decreased renin. Decreased renin is your buzzword for Conn's disease because renin is going to then subsequently make changes to how much aldosterone is synthesized. If that's down, as well as aldosterone being elevated, it's telling you that it's a primary. Whereas a secondary, let's say you have some hypertension or some kind of a tumor in the juxtaglomerular cells, that's going to overactivate RAS. So both aldosterone and renin is activated. So think about secondary as two things up, whereas primary, only one thing is up. Hyperaldosteronism, okay, this is what you need to know. Extracellular, what happens, intracellular. This is what I was telling you guys. Potassium gets exchanged for sodium, right? What also happens in terms of H+ ions, more go into the intracellular because remember, your body has to compensate. They're like, oh, wait, I don't have enough ions because most of my potassium's out. What's happening? Essentially is that potassium leaves and all of your H+ ion go into the cell. When that goes into its cell, your blood, right? Your blood essentially becomes alkalotic, right? Because there's no balancing of this acid and base pH kind of counterweight. With hypokalemia, right? Increased potassium is lost, causes muscle weakness and arrhythmias because remember, potassium is one of the major conducting components of the heart. Alkalosis because of the H+ influx of potassium H plus influx instead of potassium as a result. So you're going to present with hypokalemia and metabolic alkalosis. Okay. Decrease renin-1, so increased BP inhibition of secretion. So keep that in mind. Hyperaldosteronism, this is the breakdown summary. If you guys just need the big picture, here it is. Okay. I don't know why they like this kind of question in terms of like the ratio of what you release, but apparently it's an important thing, so I want you guys to know it. Norepi to epi, norepi is the 20% and the epi is 80%. That's just the primary thing that you guys need to know. Okay. As always, here's the summary of the entire what happens in the it happens in the medulla, right, of the adrenal gland, as well as a couple of the disorders that you guys can earmark for DM, okay, as well as what you would give for Parkinson's is also mentioned here, as well as what's happening with cortisol and norepi and epi, right? That's why when you have cortisol increase, you're going to have sympathetic tone activation because phenylethylamine methyltransferase gets upregulated, and that leads to more epinephrine being spit out, and that leads to more sympathetic activation. And what are you going to see in terms of metabolites in the body? Your VMA. Okay, catecholamines. Okay, there's acute stress and there's chronic stress. Acute stress, you're going to start spitting out like epinephrine, norepinephrine right off the bat because you want to break down, you want to give your body some fuel, both in terms of glucose as well as lipids and fats. Okay, catecholamines, instant, short acting, right? Remember, they're not full-blown responses. Whereas your cortisol, it's going to appear after a longer period of time. It's going to sustain you, and that's your chronic stress, okay? Just keep that in mind. Cortisol has very, very long half-life, so you don't just casually give corticoids to people, okay? All that summary is shown here in terms of what happens. Your glucocorticoids as well as your mineralocorticoids get upregulated with the whole blood pressure, with protein breakdown and increased immunosuppression. That's why you ever wonder during exam season why you catch a cold? It's because your body's like, I'm kind of stressed. I'm going to immunosuppress you. So I'm going to make you more prone to all these pathogens that are out there, and you can't give a proper response to it. So what happens in terms of short acting? It's going to be heart rate goes up, blood pressure, blood glucose, metabolic rate, bronchodilation, all of the sympathetic responses that you guys know from term 1 and now in term 2. Okay, thyroid and parathyroid, was a minor point, especially the thyroid. What you do need to know is more of the disorders as compared to anything else. First thing you guys got to know is your hypothalamus is going to release TRH. What is TRH? Thyroid releasing hormone. Anterior pituitary, TSH, right? It's going to spit out TSH, which is then going to subsequently act on the thyroid gland. And that thyroid gland is going to produce 2 essential hormones that you need to keep in mind, T3, T4, okay? T3 is triione T3. It's very, very much inactive unless it gets to the target tissue, right? Whereas T4 is the carrying type. It's not biologically active. It only, when it gets to the tissue, T4 gets converted to T3, and you guys can learn the general functions of the thyroid hormones based off of 7 Bs, brain maturation, bone growth, beta adrenergic effects, basal metabolic rate goes up, blood sugar goes up, and breakdown of lipids. And it's a really important point in babies because you can give babies are maturing their lungs even after they are born. So their thyroid is very much active and it stimulates the synthesis of surfactants. And you guys remember your surfactants from your CPR1 days. Okay. You guys know the action of thyroid. It's very much a sympathetic almost response with everything and growth and development. The only thing that often trips up people, it's a increased protein synthesis and degradation, but the net effect in terms of catabolic effect on proteins, okay? Net catabolic effect except on proteins. Keep that in mind. Overall, it does everything up except for catabolysis of proteins. Okay, this is a very busy slide. What I do want to say is the key enzymes to keep in mind. You got to know your 5-deiodinase. You also need to know your thyroid peroxidase, right? because those are the ones that are essentially involved in the proper iodination and deiodination and the conversion of T3 to T4. Okay, those are the hormones involved. That's what they're going to likely ask you about. Okay, so your MIT and DIT, and this confuses a lot of folks for pretty simple reasons, because it's like, why are we learning about them in terms of T3 and T4? Okay, let's keep it simple. Your T3 has one MIT and two DIT. So M is for mono, D is for duo. So like M, so 1 plus 2 is going to equal 3, right? So that's your T3. That's the biologically active one. So how much do you think you expect for your T4? You're going to have two DITs, because 2 plus 2 equals 4. That's as much as you guys essentially need to know for your thyroid synthesis pathway. They didn't get too crazy with this because the exact mechanism of action for all of the thyroid level changes isn't fully and properly understood. Literally, they threw that in here. And whenever they say they don't know, they hardly can test you on it, because they don't expect you guys to be PhD holders of thyroid level functions. But this is what they can ask you: Graves' disease versus Hashimoto. Both of them are autoimmune typically. One is a shutting down, which is Hashimoto thyroiditis. Okay. Thyroiditis, I already should tell you that it's an itis. So it's an inflammation problematic shutdown of the thyroid gland. So what are you going to have? You're going to have a decrease in metabolism, decrease in circulating glucose, all of the biological components that we just talked about in a couple of slides ago. Whereas Graves, it's overactivity, right? You're going to have the exothalamus. You're going to have a lot of like biologically active components, like your metabolic rate goes up, your respiratory rate goes up, cardiac stuff goes up. That's what you need to know. Important to note is that one of the ways you can kind of kill someone is radiated iodine. Very bad. You got to give them like the counter opposite to combat if someone has taken radiated iodine, right? You give them like a whole bunch of, I don't know, potato fries at this point, like just to like make sure that they get a bunch of iodine into their system so that the radiation can be counteracted. The mechanism of action is just competitive inhibition, because remember, a massive dosage is going to prevent the radiated iodine from being taken up and combat that entire effect of cellular damage, which you don't need to know, but I'm just putting it out there. Okay. Graves' disease, I already mentioned it. It's most common, right? It's hyperthyroidism. It's an autoimmune condition, IgG, due to an antibody basically permanently attaching to the thyroid cells and saying, hey, why don't you just like make a whole bunch of thyroid? You're going to have goiter, that's thyroid enlargement. That's like, you're going to see it. It's like a prominent bulge on their neck. You're going to have exothalamus, which is the ophthalmopathy, which is what you're seeing here, locking up. And then finally, you're going to have non-pitting edema. These are like strong edemas that are associated, okay? Would we see the same symptoms as Hashimoto and Graves? In terms of clinical features, maybe. In terms of metabolically and at the cellular level, completely opposite in terms of Hashimoto versus Graves, okay? Hypothyroidism, this is what I was talking about. Very common thing that they like to ask is thyroidectomy, because Hashimoto thyroiditis doesn't seem to be as common in terms of what they like to ask. It can also be due to an iodine deficiency. Remember, iodination and iodine trapping is one of the major steps, okay? If that isn't done properly, you're going to have a whole bunch of issues of creating your thyroid hormone, because remember, that iodination is the critical step. Secondary is insufficient pituitary action. Basically, your pituitary is shut down and it's not creating the thyroid stimulating hormone. And you're going to have some resistance at the organ level that could potentially cause this to be like, oh, like I'm not going to take this T4 that you've given me and convert it to a T3, like whatever. That's often less asked about. They prefer to ask you about Hashimoto and thyroidectomy and iodine deficiency. As always, with hypothyroidism, if it gets seriously bad, you could have some gag deposition. So it's going to have similar like exothalamus, as well as some myxedema. But there's generalized puffiness, and keep that in mind. Decreased metabolic demand is the big summary takeaway point. Okay, we're getting to the tail end. I swear we're almost done. Thank you guys for being troopers. What you need to know is that calcium distribution is important. Both intracellular and extracellular, calcium has to be tightly regulated because one, our body is highly dependent on calcium for metabolic changes. What you do need to know is that a good chunk of our calcium is hanging out in our bones. And remember, it's not biologically active because it's paired with calcium and phosphate. Calcium phosphate, it's a mineral. It's essentially deposited and makes up what a good chunk of your bone is. Less of it is in the actual circulating fluid, and the circulating fluid has very little calcium because calcium has large downstream effects, and it has to be tightly regulated in a tight margin. Okay. Ionization form is the only one that's active. So 50% is free or ionized. The rest is bound to albumin, citrate, and phosphate. Because remember, your albumin is hella important. I swear, if there's any sort of liver issues, albumin gets affected and your calcium goes completely into flux. You're going to have like tachycardia, all sorts of metabolic changes, and you got to compensate it and figure it out ASAP. Otherwise, the patient could literally die. Phosphate, okay? Majority of the phosphate isn't regulated by our system, right? It's highly dependent on the calcium that we regulate, okay? Calcium plus phosphate is typically bound and biologically inactive, and that's found in the bone. What your body does is, oh crap, I'm running out of calcium. I'm going to start breaking down the deposited calcium and the phosphate and separate it into two in order to keep myself alive. But at the same time, I'm going to start excreting out the phosphate in the kidneys. So when you are considering this in the large grand scheme of things, calcium deficiency happens primarily due to a absorption deficiency at the GIT, because 90% of the stuff that you are brought in is coming from the GIT, gut, okay? We can kind of compensate it by absorbing from our bone, but remember, when we start absorbing from our bone, there's a lot of pathological changes, and that's bad. You can also start reabsorbing from the kidney level. Keep that in mind, just something that it's not a sufficiently high amount that you can keep going. So your body's going to eventually give up. Okay, regulation, tightly regulated, is coming from the parathyroid hormone, okay? What are your cells that are doing these? These are your chief cells, okay? The PTH is the most important regulator of extracellular calcium. This is the biologically active calcium. You're going to start spitting out more phosphate in order to keep those biologically active calcium in your circulation. Whereas free calcium and phosphate levels are important for bone modeling and formation, because it's calcium phosphate that is your bone, essentially, at the end of the day. You got to know this pathway, guys. I know you covered it in T1, but they are going to ask you questions in terms of every step of the way. Let's say you didn't get enough sunlight, like some med students who are doing this virtually. You're going to have decreased levels of conversion of your 7-dehydroxycholesterol to the cholecalciferol, okay? Cholecalciferol can also be derived from your diet. This is why you take like vitamin D pills. Like, it's not as much absorption, but it still happens, so you can compensate it a little bit. The important thing is they can give you a liver issue, even though you haven't covered the liver, and say like, oh, the liver shut down. What are you not going to be able to convert it to? You can't convert cholecalciferol into 25-hydroxycholecalciferol, because the enzyme that's deficient is 25. So if you're missing the 25, you can't have the 25-hydroxycholecalciferol. Same thing with the kidneys. What you need to remember is that parathyroid hormone is going to upregulate the activation of the 1-alpha hydroxylase. That's how you get the biologically active form of vitamin D, right? 1,25-dihydroxy cholecalciferol is the full name of vitamin D when it's biologically active. Keep this in mind. It's PTH. As adults, we don't use calcitonin, or sorry, we don't use calcitonin to regulate the is it calcitonin? I feel like I'm missing this up. We don't use, is it calcitonin, Cass? Yes, we don't use calcitonin, okay? We don't use calcitonin to regulate the actual calcium levels in the system. So we hardly talk about your calcitonin process. It's always going to be PTH when they're asking questions about this. So what happens, essentially, let's look at it. Calcitonin is secreted by the C cells of the thyroid, right? It's not majorly active in the calcium homeostasis in adult human beings. In children, yes, the bone remodeling and all of that happens early on in the childhood, hella important with calcitonin. Don't forget it. Don't get it twisted. Adults, no one really cares about. It's PTH all day, every day. Okay. Primary hyperparathyroidism, it's usually due to parathyroid follicular tumors, ectopic parathyroid tissue. What happens is if you have increased levels of pH, you're going to have calcium and phosphate, polyuria, and calciuria. Why is this happening? You guys can run through the mechanism of it and you can see exactly what is happening, especially with the EKG, shortened QT interval, because you're losing those calcium, right? You have excess calcium in circulation, shortened QT, you're more cardiac sensitivity. Your phosphate is just being shut out into the urine, and yeah, you're gonna have elevated phosphate levels. Mnemonic, stones, bones, abdominal groans, thrones, and psychiatric overtones. Obviously, they typically ask about stones, bones, and abdominal groans. Those are the essential ones to keep in mind for primary hyperparathyroidism. Okay, secondary hyperparathyroidism. This is often less asked about. Dietary deficiency in vitamin D, poor absorption of fat, because remember, fat is one of the essential things we need in order to have cholesterol. And cholesterol is what makes up the backbone for all of the vitamin D and the steroid synthesis, as well as the inability to synthesize D3, kidney disease, okay? Increased calcium is needed for, especially during pregnancy and lactation. So keep that in mind, why you could have secondary hyperparathyroidism. The mom is very biologically active, so she has an increased demand, both because of the lactation process as well as her cells need it. It's characterized by increased PTH, decreased serum calcium, and decreased urine calcium, decrease serum phosphate, and increase urine phosphate in the actual urine. Okay, you guys know this from T1, rickets versus osteomalacia. Rickets, kids. Osteomalacia, adults. Very simple. What you need to know in biological context, there is decreased levels of calcium and phosphate in the extracellular fluid. Okay, vitamin D deficiency is the primary cause of this. Okay, you got to give these kids some sunlight. I don't know, they're kind of like plants. You got to give them food, water, and like sunlight. Apparently that's a thing. I don't have a kid. Okay, primary hyperparathyroidism cause, okay, you guys know this. Removal of the gland is the primary one. It's hard to kind of separate out like your parathyroid from your thyroid. So often when they're doing surgery, they can accidentally either nick this area or like completely excise it out. It's a problem. Okay, characterized by low calcium, high phosphate levels because you're not releasing this phosphate in the kidney level. Tetany, because remember, calcium is one of the primary things that deals with muscle contraction, right? And that's increased muscle excitability. EKG shows prolonged QT because remember, you don't have enough calcium to do those proper contractions. Decreased calcium of less than 6 milligrams is bad. You can die because, you know, calcium literally runs this whole cardiac contraction plus muscular contraction component. Okay, hypocalcemia. Paresthesia, you guys remember those lovely OSCE exams where you did like little tapping of people's faces? Yeah, this is the reason why we do it. We have to make sure that their calcium levels are proper, even without drawing a, you know, blood sample to see if there's calcium levels to a sufficient degree. Trousseau sign, this one is when you just like straight up torture them by increasing the blood pressure cuff to a way too high level, and they're like start spasming at the hand level, okay? EKG shows prolonged QT is a very common one, but obviously you're not hooking up every patient to a EKG. Okay, pancreas and endocrine. Very simple, insulin, okay? Gotta know it. There are two essential biological things you need to know. Okay, your beta cells are in the center, your alphas are around it. Because think about it this way, the alphas are protecting the pack, and then the beta cells are like, you know, they're beta, like they're not the alpha. Betas are important, like there's a lot of them, but like the alphas are protecting the circle. They love to ask a question based off of immunofluorescence, so know that very well. There are two disulfide bonds, okay, on the chain A and B. This is the chain A and B, and one disulfide bond with the interchain link for A. Okay, that's what's being shown here. Now, a patient comes in. they've been snacking on them donuts, okay? They're just like, whole Krispy Kreme, I got vaccinated, I'm about to destroy this thing. And the problem is you can quickly like be like, well, obviously you've been snacking on donuts because your C peptide levels are way too high, bro. Or if they've been really behind on their diet, you can do hemoglobin A1C, and that thing is active for like 3 months. Okay, like they can't lie to you. Those lab values, they don't lie. Maybe sometimes, unless someone messes it up. Endogenous insulin synthesis is important. Um, is critical because insulin is high, C-peptide is high, proinsulin, small measurable amounts. So keep that in mind. They typically ask for C-peptide in terms of lab measurements. Remember, C-peptide half-life is longer than actual insulin. So you often measure that in terms of seeing if there's like an insulinoma or some kind of issue. Okay. Honestly, don't trip about this. They don't ask too crazy with this because it's a very DM thing, but I would know the big picture. Okay, you had a nice meal. Insulin is going to go up. It makes sense because you're going to store your fatty acid synthesis, right? Because you got to synthesize those fats to be stored. Cholesterol synthesis also gets upregulated. But when you have a starving state, you're going to do the exact opposite. Glycogen gets degraded, which is the storing form of glucose. Gluconeogenesis gets upregulated because you got to turn this into ATP. And sorry, you're going to not turn it into ATP. You're going to turn it into ATP and then make sure that you're still fueled. And then fatty acid degradation, it makes sense because you got to increase your lipid and fat content in the blood. Okay, guys, I know you guys had a question with the green and red madness. So think about it this way. Insulin, look at how much they just like, it's everywhere. It's like, it's way too much. And then glucagon, you guys see it's like mostly in the border. I know it's a little difficult. Just keep this straight. Glucagon, alpha, around, okay? Insulin everywhere, but like the bordering. Just keep that safe, please. It's gonna save you so much time. Beta cells release insulin, which lowers like the blood glucose levels, stimulate the synthesis of glycogen, protein, fat synthesis. Insulin is the thing that you need to keep in mind. Alpha is glucagon. Blood glucose level has to be increased because you got to get it to the actual tissue level. Gluconeogenesis primarily and glycogen synthesis is happening at the liver kidney level. Okay, glycogen degradation. Delta, okay, don't forget this is scattered everywhere. Okay, if they ask you a question about somatostatin and they ask you about the pancreas, everywhere. Don't put inside or in the around, just put everywhere if that's an option. Okay, no one really cares about the pancreatic polypeptide hormones. No one cares. Activation, elevated blood glucose, major activator. Okay, that's the primary way the insulin gets secreted from the B cells of the islets of Langerhans. The other thing is amino acids, right? Arginine, leucine, glutamine. Okay, these are important. Think about it this way. This is why a lot of the bodybuilders take like these amino acids because these amino acids are going to induce insulin, and insulin has anabolic properties, right? It's going to deal with increased muscle growth and deposition of glycogen and storage, an active form of it. So keep that in mind. Gut hormones that you need to keep in mind is GLP. And if you guys remember back in the day, you guys learned all these like glucagon-like peptide and gastric inhibiting peptide. I think some of it, or actually they're going to be covering a little bit more of it in DM. Now, neural input, parasympathetic, very simple. Think about it this way. It's the vagus nerve coming in and going like, hey, dude, like you just had a nice meal. Why don't you just chill out? So insulin is going to start secreting, is going to start being secreted from the beta cells and lead to increased absorption in the muscle and peripheral tissues. So you can store it and use it at a later time. Inhibition. If you have a sympathetic tone, right, you're going to have issues with this. Epinephrine, norepinephrine are going to shut down this pathway, as well as your somatostatin. Somatostatin is coming from what cells? These cells, okay? Keep that in mind. It's the paracrine in the islets. It only acts at the local tissue level. It doesn't go anywhere else. So important. Why are we learning all this? This is the big picture, okay? When you guys are eating, right, a nice juicy meal, like how I should be doing right now, it's 12 o'clock here in California. What happens is your SGLT are going to help bring in glucose into the cells and eventually pass it on to the into the actual circulating content of glucose. Remember, your GLUT2 are always active, right? Your GLUT2 is going to help bring in that glucose and stimulate the pancreatic beta cells and be like, hey, dude, like we have a whole bunch of glucose circulating around. We can't have that. We got to bring it into the actual tissues that need it. So what happens is it's dependent on calcium. You guys will realize calcium has to be tightly regulated for this reason. Calcium, if it's brought in, it can then cause changes at the vesicular level of when you created these insulin. And as it gets spit out into the blood, it can then go act on GLUT4, because remember, GLUT4 is insulin dependent. That's what happens when insulin binds to GLUT4 receptors and helps bring in glucose into muscle cells as well as adipocytes. So that's what is being explained here, insulin dependency, right, of GLUT4, and that's why you need to have insulin. It has anabolic properties. It increases a whole bunch of upregulated components in DM. You're going to learn that entire pathway very well. Okay, summary of insulin action. Synthesis of glycogen, fatty acids, cholesterol, everything has to happen so you can store it. Muscles, you're going to store as well. You're going to lead to muscle protein synthesis, and that's important. And then fat cells, storage of tags and everything. And then finally in the brain, that's why you got to have like, don't go on a keto diet before an exam. Like seriously, you guys need those glucose. You don't want to be like spitting out ketones into your brain. Just keep that in mind. The primary mechanism that you function and learn and grow is due to glucose. Also, don't eat like a big meal before an exam. Like that like overcompensates it and you're like just sleepy at that point. Too much parasympathetic activation. Glucagon, okay? This is an amino acid derived thing, okay? Hormone. It's going to be changing. It's going to be short acting because you don't want to constantly have glucagon being spit out. So they don't care too much about glucagon. All you need to know is that it's the alpha cells of the pancreatic proglucagon that primarily converts glucagon into the active form. Don't need to know too crazy amounts about glucagon for now. Low blood glucose is the major trigger, as well as arginine, alanine, and other amino acids that are often released when you are starving because they are often used to create glucose directly. Epinephrine, norepinephrine, this is your sympathetic tone, guys. Cortisol, long-term stress, you can see why your muscles start breaking down and starts releasing all of the buildup that it's done when you are in a parasympathetic state. So that's why a lot of people like tell you to like de-stress if you're working out, because it's going to have greater effect in terms of muscle tone and physique. Okay, neural input, sympathetic during stress, it's going to also release a bunch of glucagon. It's going to increase blood glucose. It makes sense, right? Why would you want to do this? Because you want to increase blood glucose so that your cells can utilize it and the essential organs. What's going to inhibit it is increased blood glucose. Insulin is going to be one of the things that counteracts glucagon, right? It's a pendulum. Somatostatin, told you guys, somatostatin does both. Keep that in mind. Glucagon in the tissues, okay? What is it going to do? It's going to be do the G protein, cyclic AMP, GS pathway, right? Activates glycogen degradation, gluconeogenesis in the liver and the kidney at the same time. Because remember, what you're trying to do is increase your blood glucose level. Insulin is going to decrease your blood glucose level and store everything as much as it can. Glucagon is going to start breaking down things. Glucagon inhibits in the liver glycogen synthesis, glycolysis, fatty acid synthesis, and cholesterol synthesis, because most of the stuff gets stored in the liver, and then when it needs to be broken down, it gets broken down so that the rest of the body can stay alive and thriving. Okay, changes in blood glucose postprandial. This is prandial. I like to think is like a grandial meal, like a grande meal, postprandial. It's when the blood glucose levels are at the peak so that your body's like, hey, let's drop some insulin into this and start absorbing as much as it can. So blood glucose levels will decline after a while, right? This is post-absorptive. This is like, you fast for 8 hours overnight. Some people overutilize this and do long-term fasting so that you can, modulate the amount of fat and other things that are burned. And real starvation, okay, not just me over exaggerating. 3 days of not having food, right? You can't survive for long without food. You can't survive barely any time without water. So keep that in mind. Further decline can happen, which is kept after 40 days of starving. You can go for a pretty good chunk of time. It's crazy to see like completely people who haven't eaten in a while. Okay, you ever wonder why you're hangry? It's because of this. Hypoglycemia causes changes in the release of adrenergic adrenal components. So your body and all of your hormones are telling you like, I need to like be energized enough to go fight something and get food. So fasting in terms of blood glucose range, fasting is 70 to 110 milligrams per deciliter. 2 hours postprandial is going to be, it should be less than 120. Otherwise, you're telling that there's some kind of insulin issue. If you're in a really hypoglycemic state, you're going to get angry and you're going to have neuroglycopenia symptoms, which is the whole hangry kind of component. Some people are more kind of accustomed to this than others. So just keep that in mind. Many cells dependent on glucose for that. RBCs, brain, and retina are constantly taking up glucose. They have unique GLUT receptors that are constantly active. They don't just need insulin, they need a constant intake of glucose so that they're not insulin dependent. Insulin and glucagon are always the primary regulators whenever you're thinking of any sort of both ER and DM level issues dealing with metabolic homeostasis. Think of these two hormones. When you start thinking of secondary hormones, when you're like really in a bad state, it's glucagon, epi, cortisol, and growth hormone. Think about it. You're overly stressed. Why do you constantly want to get food? Why do you want to like binge eat or like stress eat? It's because of all of these hormones. The hormones are telling you, dude, you are in a state of poor nutritional health. I am demanding that you go get a Big Mac right now. Response to low blood glucose, right? Less than this, increase of this. This is why you get mad. Epinephrine, glucagon, growth hormone, cortisol, they're about to fight somebody, attempting to prevent hypoglycemia. That is what your body's desperately trying to do. Obviously, you're going to do this naturally. The levels of epi, norepi, glucagon, and growth hormone go up. And this is why it makes sense why you have spikes of these before you wake up, right? Like you have all this energy because epi and glucagon and growth hormone are trying to wake you up and say, hey, time to go get this bread, literally. And less than 55 milligram per deciliter, this gets bad. Like your brain and other issues start kind of taking over and you're going to be really mad. Severe hypoglycemia can cause like huge brain level changes, like irreparable level changes. Like we're talking about like 40 days of not eating, okay? And severe prolonged hypoglycemia can cause coma and death because remember, your body, especially your brain, it only runs on glucose and the constantly active GLUT receptors. Our favorite topic, alcohol-related fasting hypoglycemia. You guys are going to learn more about this in DM, but all I'm going to say is it's common to kind of get completely drunk if you don't eat properly because your body thinks you're in a well-fed state and starts storing a whole bunch of stuff, right? The abnormal high levels of NADH and NAD plus ratio, your body's like, I'm kind of fed, so it's going to reduce gluconeogenesis and it's going to lower your glucose content in the blood. So everything gets stored more. And that's why there's like a fat building component of drinking. That's why most people are like, oh, I want to become a serious bodybuilder or anything like that. You gotta one, either cut out the alcohol or like reduce it to a sufficient degree. Chronic intake can lead to like persistent fasting hypoglycemia. A mild hypoglycemic state is often seen with folks who drink. That's why people feel hungry because your body's trying to constantly balance between like, I got to eat something to like reassure that I'm still alive in a non-hypoglycemic state. So you feel hungry. That's why you should eat too. Alcohol absorption is faster when you are also like dehydrated or haven't eaten in a while. So just keep that in mind. Also, if you drink grape juice, it tends to exacerbate this effect. That's a different story for another day. Hypoglycemia due to insulinoma, okay? This is not like a complete malignancy, but this is you have too much beta cells in the actual insulin, like the islets of Langerhans, insulin producing components. you're going to have severe hypoglycemia. What you would do is you would measure the patient's C-peptide levels constantly to see if they have excess levels of it. So that's telling you in your body that, okay, insulin is constantly being churned out. It's going to have a lot of anabolic properties because remember, more insulin, more muscle deposition, not deposition, but muscle growth and fat deposition. Remember, via GLUT4, abnormally high insulin is going to be there. So you can't really like counteract it. You can't be like, I'm going to spit out some glucagon to kind of balance this out because insulin is so high. Blood contains high levels of insulin and C-peptide. We would measure C-peptide levels constantly, especially for the pro-insulin form. Okay, why are we learning this? You can artificially, for example, bodybuilders will cheat this system and sometimes take a shot of exogenous insulin, and it can kind of give you like very unique lab values because insulin can be high, but your C-peptide, remember, C-peptide and your pro-insulin are all endogenously created. So they're going to be low, which makes no sense. Like, why would you have high insulin and low C-peptide? That's because someone's taking a shot of insulin. And low C-peptide and low to absent proinsulin is something to keep in mind. Then also you can consider sulfonylurea drugs because sulfonylurea helps your pancreas make extra insulin that is endogenous, okay? This is the important thing. Sulfonylurea drugs are endogenous insulin. No one's giving them extra shots of insulin. They're making it themselves, organic, it's homegrown, important, right? It's like your local farm. High insulin, high C-peptide, pro-insulin is going to be present, as well as sulfonylurea amount in the actual blood sample that you're going to run. That being said, that is my spiel and the review for today for you guys. I'm going to stop the recording and we are going to open it up for questions. Thank you all for coming. So, I know this is a big review, but I wanted to make sure you guys have like all the knowledge that you guys can before going in to this, exam.